entering through the anus. So this is the contrast enema. And here you can see in the VCUG, that's the bladder, that's the urethra, and you can see the colon here. So how are you going to prepare for surgery? Golightly, oral antibiotics, doing a colostomy, enemas, or no bowel prep? Everybody can vote. And let's see the answers. So the majority said colostomy prior to surgery. I think this is a good answer. So you can either do a colostomy, let the site rest, depending when was the operation, and then reoperate. But if you want to try to do without a colostomy, you're going to have to clean this bowel completely and have authorization for the parents to open a colostomy at the same time if you are concerned about your repair. Remember, colostomy is always the safest option. But if you're going to do it without a colostomy, you have to clean this bowel completely. And reoperations are not easy. So that's when we need to be humble and be prepared, because you never know what you're going to find in reoperations. And some of them are very, very hard. So this is a 3-year-old female patient that has only one single stoma where the stool comes out. So they did a Hartmann pouch. And this is the contrast study. So you can see one catheter here, one catheter in the vagina, one catheter in the bladder. So this is either a rectoperineal fistula or a rectovestibular fistula. So what type of bowel prep does this patient need? Golightly, oral antibiotics, revise the colostomy prior to surgery, enemas 24 hours prior to surgery, or no bowel prep. And everybody can vote, and let's see the answers. Okay, that one, I am not going to accept Golightly. Why? Because the Golightly will only clean the proximal bowel. It will have no effect in any area of the surgery. So Golightly here is the wrong answer. Yes, you can revise the stoma. This is a hard decision because technically the patient is diverted. So in this case, I don't see a purpose of revising the stoma. The patient is diverted, so your surgery will be protected. We would normally advise to revise the stoma if we need to do the distal colostogram. In this case, we were able to get the contrast material, so we have all the information. We know where is the rectum. We know we have enough bowel, because in perineal fistulas and vestibulars, you don't need a distal colostogram. You already know that the rectum is right there, and you already know you will have enough bowel. So I don't think you need to revise the colostomy in this specific case. You can try to do an enema, a quick enema, just to clean, or you can do without bowel prep. I think in this case, during the contrast study, we were able to see that the distal portion is clean. So you would be safe without bowel prep, or you could do a gentle enema to be sure that everything is clean prior to your surgery. But again, in this case, Golightly would not be an option. So this is a 10-month-old male patient that has a diverting colostomy. So this is the distal colostogram. I want you all to look careful. And again, I prefer to do this courses in person, because that's when I would ask the audience, what malformation is this? And I carefully wait for the answer. And the answer that I'm looking for is, I don't know. You cannot tell with this distal colostogram, because this is an incorrectly done distal colostogram. There is not enough pressure, and I don't know what malformation is this. So you can see the mucous fistula. You can see that there is contrast here, 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 and then it's almost flat, but you can see that it's starting to try to show us. So they stop the study prematurely. So I don't know, I'm not seeing where is the connection with the urinary tract, but I can bet money that there is a connection because I see this beak here. So if you receive this study, you cannot accept and you cannot operate on this patient. You have to go back to radiology and you have to do the study again until you have all the information. The distal colostogram is the roadmap for the surgeon. It's our obligation to only operate on the patient if we have the right map. So for a distal colostogram, you need to see the sacrum, you need to see the anal marker, you need to see the mucus fistula, you need to see where it connects to the urinary tract. So ideally, you want to see the bladder, you want to see the urethra, and you want to see exactly where is the connection. So you plan well. Now, what information I can have with this colostogram is that regardless of the type of malformation, I do have enough bowel for the pull-through, because imagine that you have to stretch this piece of bowel. So this portion reaches here. So you know you have enough. So for the question that I'm going to ask, that it's regarding bowel prep, you have the information that you need. So what type of bowel prep does this patient need? Golightly or antibiotics, irrigation of proximal stoma, irrigation of distal stoma, or no bowel prep? Everybody can vote. And irrigation of distal stoma. Very good, because we know we have enough bowel and we're not going to touch the proximal colostomy. So I hope this concept is clear on everybody's mind. So how do we do our Golightly bowel preps? We use a very small nasogastric tube and we run the solution 25 mL per kilo per hour for 4 hours. And then we repeat the cycle until the patient is completely clean. We give IV fluids in all patients while they are receiving the Golightly, and we let them have clear liquids in between the Golightly cycles. Then we keep them NPO, we stop the clear fluid liquids 2 to 4 hours prior to the procedure. This truly depends on your anesthesia protocol. I think currently at our hospital, they are allowing us 2 hours, but that changes from hospital to hospital. So you have to check what is the anesthesia protocol at your institution of when they have to stop clear fluids. How do we do irrigation of the distal stoma? We use a small Foley catheter and we irrigate with normal saline solution, 100 mL at a time, and until it's clean. During the day, the patient can have regular diet, and then again, it's going to be on clear fluids and NPO time according to your anesthesia protocol. Postoperative management, we keep our patient with antibiotics for 24 hours. We don't do antibiotics during bowel prep. We just do antibiotics during anesthesia, and we keep it for 24 hours. Patients with colostomy that did not have a laparotomy, that just underwent PSARP, when they wake up from anesthesia, they can eat. Patients with laparotomy, they can eat the next day if the colostomy is working and the abdomen is not distended. Now, patients without a colostomy, we did bowel prep, we're gonna put a PICC line and we keep them usually 7 days NPO, nothing by mouth, on parenteral nutrition. Why? Because dehiscence, separation of the tissue, happens between day 5 and day 7. So on day 7, we look, if everything is fine, patient eats and can go home. If there is a separation of stitches, you still have a clean area and you can put extra stitches. Foley catheter. So for male patients with rectoperineal fistula, we keep the Foley catheter for 1 day. So we do the PSARP, next day we remove the Foley catheter. For patients with bulbar, prostatic, and bladder neck fistulas, we keep the catheter for 1 week. So the patient is in the hospital usually only for 2 days. They go out of the hospital with the Foley. We keep the Foley in a double diaper. And then they come after 1 week, early in the morning. We remove the Foley. We instruct the family to give a lot of fluid. And here in the United States, we have that pumper diapers that has the yellow line. And when the baby pees, it turns blue. So we only let the patient leave the hospital once we have a blue line that the patient has peed enough without difficulties. Now, in patients with cloacas, we keep the Foley catheter 2 weeks when we do a total urogenital mobilization. And when we have to do more, or when we have to do vaginal replacement, we keep it for 3 weeks. Why? Because the area gets very edematous. And in case we take the Foley, it's very hard to reinsert. So we keep for 2 to 3 weeks. Now, the dilation protocol. First of all, when you do a good pull-through, good blood supply, dilations are not painful. All what we are doing is not truly dilating. We're just avoiding the natural healing process from healing, closing the anus. So we teach the families in clinic how to do the anal dilations. They come to clinic around 14 days after surgery, and we start with a small Hager, usually number 8 or number 9. And that's just for the family to learn, to feel confident. Number 8, number 9, it's usually doing nothing, but that's our protocol. We start with a small Hager, and we are going to increase the size every week and until the patient reaches the final Hager according to the size. So if you're operating, for example, a baby that is 3 months of age, the final Hager size will be a number 12. If you're operating on a 5 months, the final Hager size will be a number 13. So we use the Hager dilator 30 seconds, take it out, 30 seconds, take it out, and we do it morning and evening. And every week, the patient will increase size until they reach the final size. Once they reach the final size, then we are going to start decreasing the frequency of anal dilations. Instead of doing twice a day with the final size, they are going to do once a day for a month, then every other day for a month, every 3 days for 1 month, 2 times a week for 1 month, once a week for 1 month, once a month for 3 months, and then that's it. If dilations are painful, probably you have a real stricture. If you have a real stricture, you should stop dilations. This patient needs a reoperation. So dilations should not be painful, and they are done at home. Parents do it without a problem. Now, the mother of one of your recently operated patient that is doing anal dilation calls you because she cannot increase the size of the Hager dilator. What do you recommend? Dilation under anesthesia, go back to the previous size, stop the dilations, just do it, or reoperation. Everybody can vote, and let's see, do we have a poll for this one? Maybe we don't.
We don't, no.
Okay, so for this one, I have to say the difference between one dilator and the next is 1 millimeter. So if they can pass the previous, they will pass the next one. So the right answer is just do it, but that sounds too aggressive. That's not what I normally do. Whenever a parent is having difficulties, I always say, come to clinic. If the patients are local, I'll show them. And usually we can do it without any difficulties. And the parents say, I can't believe it's that easy. It was not like that at home, I swear. There are many ways to do it. I always encourage parents to sing to the babies as they are doing, blow on their nose. Usually that distracts the baby and they relax. So, but again, dilation should not be painful. And if you can pass one size, you can pass the next size. I really brainwash the parents of my patients and they do it without problems. Why anal dilations are important. So here you're seeing the picture after our operation, if you're dealing with a patient with good prognosis, the anus, as we cut the sutures, will look closed. So if we let it heal like that, there will be a ring-like stricture at the skin level. So that's why we do anal dilations, to avoid that ring-like stricture to be formed. Now, this is an example of a ring-like stricture. Now, if you do an anoplasty like this, which I hope you don't, that looks like a colostomy, this patient doesn't need dilation. There's no way that this anus will stricture. So I think when people talk about dilations or no dilations, unfortunately, we don't see their repairs. We have to understand that repairs are different and patients are different. There are patients that they have very poor prognosis for bowel control, that even after a perfect operation, the anus is petulous. That patient will not stricture, but the patient with good prognosis, that's the one that needs the dilation the most. Time for colostomy closure. We will close the colostomy when the final size dilator has been reached and it's passing easily. Then we can close the colostomy, but the patients will continue doing the dilation protocol until the end, because the healing process takes about 6 months. What do we do for colostomy closures? We don't do formal bowel prep with Golightly, but we ask them to have clear liquids, and we irrigate both stomas just to decrease contamination. We don't like to have stool in our operative field. We keep antibiotics for 24 hours. And then currently we are following the ERAS protocol that is called Enhanced Recovery After Surgery. So if surgery went really well, we let them have clears on the same day after surgery, and we advance to regular diet as tolerated. Now for Malone procedures, well, preoperatively, if we know the patient has an appendix, the patient does not need any bowel prep. So we have the patient coming from home to have surgery, and the patient is admitted postoperatively. After surgery, they can have clear liquids, and we advance. And then we do the first enema 24 hours after regular diet. Now, we keep the catheter, the 8 French feeding tube, in place for 1 month. After 1 month, the patient comes to clinic and we remove that catheter and we teach the family how to insert. And we recommend keeping the ACE stopper for 6 months, just because of the healing process. After 6 months, they can take it out. They don't need a tube anymore. And they can start using, and even when the catheter is in place, they start using it right away. So this is a picture of a contrast enema. And I took this picture because it's extremely unusual to see the appendix on this contrast enema. So I hope you all have spotted already. But this one, we were lucky enough to see the appendix. I don't recommend anyone trying to do a contrast enema with the goal of seeing the appendix, because you won't see it. Those are rare events. Whenever they happen, I take a picture. But in this case, I saw the appendix. It's great. The patient does not need bowel prep. Now, for older people, so when I went to medical school, I learned if you enter the abdomen of a child, you take the appendix. Hopefully, this is no longer taught in medical school, because the appendix is extremely valuable for Malone's and Mitrofanov. And nowadays, I would say we're seeing less and less, but in the past, it was not uncommon to enter the abdomen and find that the child had no appendix. So when the child has no appendix, either because it was taken out or it was used for the Mitrofanov, then we will have to do what we call a neo-Malone, or a continent neo-appendicostomy. We do it by using a colonic flap. And for those patients, because we're gonna open the colon, we're gonna use a lot of sutures, we do Golightly bowel prep. And then post-operatively, on the next day, if the patient is not distended, we let them have clears and advance. We again keep the catheter in place for a month. Now, depending on the position of the catheter, we may use that catheter or not. The problem is, even when we try to guide that catheter, sometimes it curls and it's pointing exactly at your suture line, and you don't want to flush a large volume in your recent suture. So here's an example of the catheter that it's pointing towards our sutures. So in this case, we would recommend doing rectal enemas until this catheter migrates. But here's an example of a catheter that it's in good position. It's in the descending column, so you can use this catheter. So that's how we decide if we can use the catheter or if we have to do rectal enemas. And I think that's all I had. I'm gonna stop sharing my screen and I will try to answer a few questions. Any good alternative as a dilator once you run out of the standard dilators? I don't have alternatives. We usually have the metallic ones that in the United States is very easy. They can be ordered online. And at the hospital, we have one that looks like candles that can be used. But I know some people have made dilators out of candle. So I'm gonna continue answering questions in the chat, but I see that our next speaker, Dr. Duncan Wilcox, is already ready. So it's my pleasure to invite Dr. Duncan Wilcox. He's our surgeon-in-chief and our urologist colleague, and he will be talking about urology concerns in anorectal malformation. So welcome, Duncan.
Thank you very much. I'll just share my screen and you see my screen properly?
Yes.
Perfectly, yes, thank you.
Excellent, thank you very much. So what I'd like to do this morning is talk about some of the urological concerns we see in patients with anorectal anomalies. As you're well aware, on the second day of this course, there are a significant spectrum of anomalies in patients with anorectal abnormalities. They can have, as you see on the left, a somewhat minor perineal, where on the right, a much more complex cloacal anomaly. And as with patients and their fecal problems, the urinary problems are much more likely in those with the more complex anomalies, such that it is rare for patients to have significant continence issues if they have a perineal fistula, where it is rare for somebody with a cloaca to have normal voiding and continence. So why should we worry about urology and why I would advocate that a urologist should be part of every one of these clinics is that we need to prevent renal damage. About 6% of all comers with anorectal anomalies will develop chronic kidney disease that requires renal replacement therapy. And almost the only cause of death in patients born with anorectal anomalies are those suffering from chronic kidney disease. About a quarter of our patients will have urinary tract infections, frequently recurrent, and clearly this is a problem for the families and the patient and something that urologists need to be present to help with. We need to improve continence. In most adult series, somewhere between 10 and 35% of patients continue to have weekly or daily episodes of urinary incontinence. And so we need to manage that. And finally, as adults, we need to help with their sexual dysfunction. Here in Denver, we are fortunate enough to have Dr. Dan Wood, a transitional urologist, and Dr. Veronica Alanis, a pediatric and adolescent gynecologist, who manage these problems for us. And I would suggests that in managing these patients, it's important to identify people in whom you can transition your patients onto, so that problems with long-term continence and long-term sexual dysfunction can be managed. So where do I see the role of the urologist? I think this can be in three areas. One is prior to the reconstruction, where I think it's important that the whole of the genitourinary tract is evaluated. And also to manage patients who unfortunately get urinary tract infections prior to reconstruction. During reconstruction, I think we have a role with endoscopy in understanding the anatomy of patients. I think this is particularly so of female patients and a cloacal anomaly. But I also think it can be valuable in males, especially those with a higher fistulae, because it can identify where the fistulae enters the urinary tract and can give you some indication of whether catheterization in the future is going to be possible. I think there are a number of GU anomalies that can be reconstructed at the same time as the anorectal anomaly or at the timing of colostomy closure. And I think this is obviously good for the families. And finally, I would advocate that for more complex problems, especially cloacas, it is valuable to have a urologist participate in the reconstruction. Post-reconstruction, we're important in terms of protecting renal function, for managing problems with continence and any genital anomalies. So I'd like to talk about some studies that have looked at urological abnormalities. This is a study that Stephanie Warren did when she looked at patients prospectively and investigated their renal tract completely, and showed that more than 3/4 of the patient had some abnormality of the urinary tract. And this can be in all areas. It can be renal structural anomalies, and we'll talk a little bit more about that. Abnormalities in renal position, which are interesting, but not necessarily symptomatic for the families. Ectopic ureters, and this is particularly common in patients with cloacal anomalies. And in rare cases, they can have bilateral ectopic ureters, which leads to abnormalities in bladder development. And this is a problem we saw in about 4% of our patients with cloacal anomalies. And then vesiculoureteric reflux is very common in patients with anorectal anomalies, with over 50% of patients developing VUR. How you investigate for VUR, I think it's very dependent on your philosophical approach to the management of patients with VUR. If you believe that VUR should be treated when symptomatic, i.e. when they've had recurrent urinary tract infections, then I think it is reasonable to not do a VCUG in these patients early on. In terms of renal anomalies, you see the whole spectrum of renal anomalies, from a hydronephrosis or so-called pelvo-ureteric junction obstruction, through duplexes, solitary kidneys, and those with renal dysplasia, as identified on renal nuclear studies. It is important to remember that patients who have renal anomalies and anorectal anomalies, the renal anomalies do not need to be treated any differently from those patients who do not have anorectal anomalies. So you can treat your UPJ obstruction just the same way by observation, and if observation doesn't lead to resolution, to more definitive reconstruction. So what about patients who get urinary tract infections prior to any reconstruction? I think one of the things that is really important to consider in these patients is whether there are feces going into the distal colonic loop. and so constantly reinfecting the bladder. And in these patients, I think it's important to wash out the distal colonic loop to make sure that there is no feces present to minimize colonization of the bladder. A number of patients, as we'll see, do not empty the bladder correctly or completely, and this may be due to a neuropathic reason, or sometimes in the case of patients with cloacas and a large hydrocolpos, it may be a physical obstruction. And so it's important to ensure that the bladders are emptied in a regular way. Usually this can be done by clean intermittent catheterization, although in patients, male patients with fistulae, this may be difficult because the catheter may preferentially go into the fistula. However, with the use of catheters that have a slight curve at the end, this can usually be overcome. In patients with cloacas, it's usually possible to empty the bladder even with a hydrocolpos with clean intermittent catheterization, but on some occasions it's obviously necessary to do a vaginostomy. Rarely is it necessary to do a vesicostomy, but occasionally it is, and this is something that obviously can be reversed at the time of the reconstruction or at the time of the colostomy closure. So knowing what urological anomalies exist in patients with anorectal anomalies, what investigations do I think are important preoperatively? Clearly, I think all of these patients should have a renal ultrasound scan. And if there are any abnormalities on the renal ultrasound scan, I think it's appropriate to do some sort of renal nuclear study so that function can be assessed prior to reconstruction. If your group has a tendency to treat reflux more aggressive surgically, then I think a VCUG is appropriate. And then spinal imaging needs to be performed because, as we'll see, at least 25% of these patients have some sort of a spinal anomaly. The type of spinal imaging, I think, is very dependent on your institution. In many institutions, ultrasound scan is done as a screening test, and if that is normal, no further investigations are done. However, if in some institutions an MRI is done as a primary study, and I know that most neurosurgeons, if they're considering reconstruction or surgical intervention, will require an MRI of the spine. Prior to reconstruction or at the time of reconstruction, I think cystoscopy is extremely valuable. I think cystoscopy and vaginoscopy can really delineate the anatomy extremely well, can measure the common channel, can assess the urethra and bladder neck, all of which I think are important for prognosis. And they, in my opinion, are more useful than other preoperative imaging. The other preoperative imaging that obviously you can do to understand the common channel is a genitogram. I think that these can be excellent, but sometimes confusing, and I would certainly recommend that if you want to get the most out of a genitogram, that you're present at the time of doing it. We are fortunate enough to have a radiology team who are very expert on complex 3D reconstruction of CT scans, which give us excellent preoperative imaging too. There are a number of genitourinary problems that urologists see which can be combined with the GU reconstruction. Typically undescended testicles, which are common in boys with anorectal anomalies, or hyperspadias, as you see here. These can be reconstructed at the time of the anorectal reconstruction or at the time of colostomy closure if there's a colostomy. And in general, we prefer the latter. Obviously, in girls, especially cloacal girls who have vaginal septums, this is relatively easy to repair at the time of the reconstruction. Post-reconstruction, the important things for urologists to consider are protection of the renal function, managing urinary continence, and any genital issues, typically testicular pain, and for Dr. Alanese, menstrual problems, and for Dr. Wood and Dr. Alanese, sexual dysfunction. So this is a study that we performed a number of years ago, looking at GFR in patients with anorectal anomalies. And we found that more than half of our patients had CKD3 or worse, and many of them had minor degrees of CKD. So really, this is data that others have also shown, that many studies show that at least 6% of patients with anorectal anomalies will go on to the chronic kidney disease that will require a renal replacement therapy. So how can we protect the renal function? Well, obviously the most important thing to do is to minimize urinary tract infections. As I mentioned, about 25% of our patients will get a urinary tract infection. To do that, we obviously ensure that the constipation is managed, and it's amazing to me how frequently, when constipation has been actively managed and regular rectal emptying occurs, how urinary tract infections and urinary continence can be significantly improved. In terms of bladder emptying, obviously voiding is the best way, and we have found that biofeedback can sometimes be helpful in children who have problems emptying their bladder and have detrusor sphincter dyssynergia, and can sometimes be useful even in patients who have minor degrees of neuropathy. In some patients, clean intermittent catheterization is necessary, and that can be either through the urethra, which is obviously ideal, or through a catheterizable conduit. Prophylactic antibiotics for those patients with high-grade reflux, grade 3 or above, has certainly been shown in the RIVER study to be helpful. And we have a tendency in those patients with chronic recurrent urinary tract infections and no reflux also to use prophylactic antibiotics, as shown in the PREVENT study. We manage patients with hydronephrosis in the same manner that we do in patients without anorectal anomaly, and we do everything we can to improve bladder mechanics. So if we look at the urinary continence rate in all comers, this is what I would refer to as intermediate term. This again is work that Stephanie Warren did. And you can see in these patients who are 5 years of age, that if you have at the bottom of the table a low anorectal anomaly, that the vast majority of these patients, 90%, are dry and voiding normally. That still, however, means that 10% have urinary issues. However, if you look at cloacas or bladder necks, then the majority of those people are not voiding normally, but are dry through clean intermittent catheterization. In this study, looking at the adult rate of urinary incontinence, this is a study done by Melissa Witten, you can once again see that in those patients with low anorectal anomalies, the majority of those are avoiding and not having urinary problems. Although interestingly, we saw that a number of patients had weekly episodes of incontinence. In those patients with high anorectal anomalies or cloacas, more than half of cloacas had weekly or daily episodes of urinary incontinence, and 25% of high anorectal malformations had problems with urinary incontinence. What was interesting to me is that frequently you hear that as people go through adolescence, that things will improve. And this data does not seem to support that, suggesting that if young children have problems with incontinence, that this is likely to persist. What is definitely true is that families and older patients get better at dealing with their continence. In terms of how the bladder was emptied in these patients, if you have a low anal rectal malformation, almost all of these patients will be voiding normally. This is certainly less true in patients with cloacas or high anal rectal malformations, in particular those with bladder necks, where the majority of those will be catheterizing either urethrally or through a mitrophenol. And as I mentioned earlier, urethral catheterization for patients, female patients, especially those with cloacas, is relatively easy and quite common to be able to perform. For those with high anal rectal anomalies, it is more difficult because frequently the catheter will go into the fistula site. This is data from other studies looking at the rate of urinary incontinence. As you can see, the rate varies. You'll also see that there have been very few more recent studies in this area. And if you look at the two studies, the one I presented and the one by Rintala, are looking at adults, up to a third of patients will continue to have problems with urinary incontinence. So the risk factors for incontinence are spinal anomalies. Clearly, if they have a neuropathic bladder, they're more likely to be incontinent. The severity of the anomaly, with the more severe being more likely. And then a much more subjective thing was the bladder neck. If you evaluate the bladder neck either on imaging or on cystoscopy, if it coapts well and closes, then those patients are much more likely to have normal urinary continence. And finally, as we'll talk briefly about, surgery can impact it. So this is work by Thomas Boomers, in which he showed that urinary incontinence was present even in some patients with a normal sacrum, but much more common with those with an abnormal sacrum. And if you have known spinal cord injury, spinal cord problems, even a higher rate of urinary incontinence. This was interesting work done by Thomas Boomers and repeated by us, in which we looked at urodynamics pre-reconstruction and post-reconstruction. And what we found was that in about 20% of times, there was a change in the urodynamics, usually from a overactive to an underactive bladder after reconstruction. And in about half of those, it resolved. And this is almost certainly due to some neuropraxia of the innervation to the bladder. And post-mortem studies have shown quite convincingly that in patients born with anal rectal anomalies, the innervation to the bladder runs very close to the fistula. So it is absolutely important, as I know Dr. Bishop and Dr. Pena have stressed, to remain close to the fistula and in the midline. So what other male genital anomalies are there? Well, about half of patients will have some anomaly. Undescended testicles is the most common. A bifid scrotum is also seen frequently, and sometimes the fistula site in perineal fistulas runs in the middle of the bifid scrotum. And then all penile anomalies have been seen. The two most common are being hyperspadias and chordee or curvature of the penis. One particular thing to note is that a number of adolescent boys and young men with a history of anal rectal anomaly will develop testicular pain. And while testicular torsion is something that clearly needs to be excluded in these patients because it's a surgical emergency, these patients have a much higher rate of epididymitis and epididymo-orchitis, and this really needs to be considered in these patients prior to going to surgery. And in some patients, that is so frequent that on rare occasions, it is necessary to do a vasectomy to stop the recurrent epididymo-orchitis. There have been few studies looking at fertility rates in men with anorectal anomalies and no paternity studies. But in this study, they looking at 30 males, 11 of them partners had conceived, but 4 required IVF, suggesting in the study that fertility may be reduced. And we know that fertility is reduced in patients with CKD, so this also may be a factor. Similarly, girls have a number of other genital anomalies. The most common being ones of septation anomalies. And I know that Dr. Anomalies will speak more about that. But hamartomas and hemangiomas in the perineum are more frequently seen in children born with anorectal anomalies. Hamartomas frequently can improve with time. They seem to get less obvious, and so that is certainly something to consider prior to removing them. And my limited experience with hemangiomas is that it is very advisable to wait until the hemangioma has resolved or has been treated prior to doing the reconstruction, because when I did a reconstruction on somebody with hemangioma, it completely healed up and the reconstruction needed to be repeated. So how should we follow these patients up? I personally believe that we should follow all of these patients with anorectal anomaly until they are potty trained or socially continent. Typically, children born with anorectal anomalies potty train a little later, and so it may be 4 or 5 before you see normal potty training. I think during that period, they should be managed and their renal function and bladder function assessed. And in those with more severe problems, i.e. those who are getting persistent urinary tract infections, those with urinary incontinence, and those with cloacal anomalies, I believe that these patients should be followed forever. And once the pediatric team has they've outgrown to the pediatric team, they then should transition on to a transition team. So in conclusion, why worry about urology? Well, I think we should worry about urology because between 10 and 35% of these patients will have long-term problems with urinary incontinence that will need to be managed. About 6% of patients will have chronic kidney disease that requires renal replacement therapy, and more will have chronic kidney disease that will probably require the input of nephrologists. About half of these patients will have genital anomalies both in boys and in girls that may require some further reconstruction. And sexual dysfunction, especially infertility, can be a problem and need to be actively managed. So finally, when to call urology? Well, I think really any anorectal anomaly could be seen by a urologist, but I think anything that is more complex than a perineal fistula should certainly be seen by a urologist or someone interested in urology. I think any patient who has sacral anomalies, specifically tethered cord, and any with other GU anomalies or further urinary tract infections. Post-reconstruction, all patients who have urinary tract infections or incontinence should be followed until they become continent. And simply, when in doubt, I would ask for a urology opinion of these patients. Thank you very much for your attention today.
Thank you, Dr. Wilcox. And there are several questions for you. So I wrote them down and I have the impression some of them you answered during your lecture, but I'm gonna still make it since people typed in the chat. Is there an association between anorectal malformation and hypospadia?
Yes, there is. I don't know the exact rate, but somewhere between 10 and 25% of patients, male patients, will have some penile anomaly, of which hypospadia is the most common and chordee is the next most common. So yes. Perfect.
The other question is, how do you manage urethral stricture and diverticulum after correction of anorectal malformation?
So in terms of diverticulum, what this typically is a persistent portion of the fistula tract. And so sometimes you can manage that. Well, how they present is typically with post-void dribbling or mucus at the hiatus. They may present with urinary tract infections as well. In those patients, sometimes it's possible just to help with voiding and get them to stay a little longer, and that is sufficient. Unfortunately, if they have persistent problems with post-void dribbling, then it is more likely that you're going to need to do a redo reconstruction and remove that fistula. So that is that. In terms of strictures, if it's a minor stricture, sometimes you can get away with just dilatation. But if it's a more significant stricture, unfortunately, you're going to need to do a more formal urethroplasty and open up that stricture.
Wonderful. The next question is, do you advise voiding cystogram for all males with rectal urethral or bladder neck fistula?
Yeah, I think that it's really important to understand where the anatomy is. And I think that that's an excellent way of doing it, especially if you wish to look for reflux. I think in those in whom you're not so interested in reflux, then you could do an endoscopy at the time. But I think that doing a voiding cystourethrogram is really important for these patients. Yeah.
Good question here. When do you decide to do urodynamics?
Okay, that is a great question. In some experimental groups, and I've certainly been one of them, I advocated doing urodynamics on all patients. I think that is probably too aggressive. And now I would be inclined to do urodynamics on patients who have spinal anomalies. I would do them on patients who have high anorectal anomalies, sort of bladder neck fistulae and cloacas, because I think their chances of having an abnormality in the bladder are very high, and it's nice to know that so that you can manage it accordingly and give prognostic advice. If I were to do urodynamics, I would usually recommend waiting at least 3 months after the reconstruction.
There is another question related with urodynamics. What is the most common urodynamic profile in an incontinent female cloaca?
That's a very specific question. And in cloacas, it's usually a bladder that is that poorly contracts. It's a compliant bladder that poorly contracts, leading sort of underactive bladder, leading to problems with incontinence due to overflow. And that is thankfully relatively easy treated with clean intermittent catheterization. That's not the case in patients with other anorectal anomalies where overactivity is more commonly seen.
There's a question about relationship between sacral ratio and risk for vesico-urethral reflux in anorectal malformation.
Okay, so I don't actually know the answer to that question. I think because sacral ratio is more commonly associated, or abnormalities in sacral ratio are more commonly associated with abnormalities of bladder emptying, and bladder emptying is more commonly associated with reflux, I would suspect that if you have abnormalities of sacral ratio, you are more likely to have the vesico-uretary reflux, but I'm not aware of data to prove that.
I'm going to ask 2 more questions and then I'll let you answer in the chat because the questions keep coming. One is, what's the time for the cystoscopy? And if during the cystoscopy you measure urethral and vaginal length?
So the time of the cystoscopy, I think, can be variable. I think most frequently we do that at the time of reconstruction, so just at the time of reconstruction. But if a patient is born here, we will often do it at the time of colostomy so that we can plan better the timing it takes to do the procedure. The reason for us to do it at the same time is if patients have traveled a long way, clearly they don't want to have 2 anesthetics or 2 trips. In an ideal world, it would be nice to do the cystoscopy prior to reconstruction so that you can really plan it, because obviously a common channel of 1.5 centimeters is a much easier, quicker procedure than one of 4 centimeters. In terms of the second, yes, we measure both the urethral length and the cloaca, the vaginal length, and the length of the common channel.
And the last question that I'm going to make live is, what's the right time for bladder augmentation?
Okay, so the right time, there are many answers to this question. If it's related to getting continence, the right time is when the family and the patient wants to be continent. And I would advocate that the patient should be wanting it as well, because otherwise they won't catheterize. If the problem is one of upper tract deterioration, then the timing to do augmentation is that at the time that you realize that the upper tracts are at risk.
Perfect. Thank you so much, Dr. Wilcox. If there are any other questions, I think we answered most, but you can certainly type in the chat. And I think Dr. Wilcox will be for a few minutes answering in the chat. And it's my pleasure to now welcome Dr. Veronica Alanis, who is the gynecologist in our team. Welcome, Dr. Alanis.
You're on mute, Veronica.
I'm not seeing Dr. Alanis.
Yeah, she's here.
Okay, perfect.
Can you see me and hear me okay?
Yes.
Yep.
Yeah.
Okay.
You just
Let me-
share your, yep.
Yes, sorry. I'm sharing right now. Give me just a minute.
Okay.
Uh, Okay, can you guys see my screen okay?
Yep, perfect.
Yes.
All right. Thank you for having me. I'm going to be talking about obstetric and gynecologic considerations in patients with anal rectal malformations. And I'm here in the section of pediatric analysis and gynecology at Children's Hospital. And really, these concerns can arise during all stages of life. So we see GYN issues certainly during infancy, with puberty and menstruation, sexual intimacy, fertility, and then pregnancy. Uterine anomalies in patients with anal rectal malformations are common. The most common Mullerian anomaly is uterine duplication. And we see this in about 34% of all patients, most commonly in patients with a cloacal anomaly. And then the second most common is vaginal agenesis, which is seen in about 5.6% of patients, more commonly in patients with a vestibular fistula. So a question to pull for the group: what is the most common vaginal anomaly in patients with anal rectal malformation? Vaginal atresia, vaginal stenosis, a longitudinal vaginal septum, or a transverse vaginal septum? And the answer I just gave to you guys, the longitudinal vaginal septum. So that is uterine and vaginal duplication. So in childhood, this really doesn't have any implications, but we do see implications of uterine and vaginal duplication in adolescence and adulthood. So patients with a persistent longitudinal septum can present with dyspareunia or painful intercourse, and then difficulty with menstrual hygiene. So if the septum is left in place, women will place a tampon if they want to use tampons, usually on one side, and then have continued bleeding from the other side. And then we can see issues with pregnancy as well. So with the didelphys uterus, specifically the double uterus, this is associated with fetal growth restriction, preterm labor, preterm birth, fetal malpresentation, so fetus in the breech presentation, and then therefore increased risk of C-section. So considering these increased risks with pregnancy, we do recommend increased pregnancy surveillance. So these patients, it's recommended that they get cervical length, so checking the length of the cervix to assess for risk of preterm birth every 2 weeks, starting at from 16 weeks gestation to viability around 24 weeks gestation. And then to assess for growth restriction, getting a fetal growth scan every 4 weeks, and that's usually started around between 20 and 28 weeks gestation. So when we think about vaginal agenesis, the majority of these patients will have complete Mullerian agenesis, where the uterus and the vagina are underdeveloped, and that's seen in about 80%. But some will have partial or distal vaginal agenesis, where just the lower part of the vagina didn't develop. So these patients will have an upper vagina and or upper hemivaginas and a uterus or didelphys uterus. And we know that anorectoplasty can create some scarring in the perineum. So vaginal replacement is generally recommended during the initial reconstruction in cases of cloaca and vestibular fistulas. And there are a few options for vaginal replacement. So if the sacral ratio indicates that the patient is likely going to have fecal incontinence, then the distal rectum can be left in place for neovagina. But if the patient is expected to have good bowel control, then typically descending colon is used as the graft. And descending colon is chosen because it's easier to mobilize and has a good blood supply. And so a segment is harvested, taken down to the perineum with its mesentery and blood supply. And if this reconstruction is done during the initial repair, then post-op dilation is not recommended because of young age. But these patients should be evaluated for patency to make sure that either the anastomosis between the upper and the native and neovagina is patent. This should be assessed and can be done at the time of colostomy closure. So another poll, what is the frequency of vaginal agenesis in patients with anorectal malformation? And it looks like about half got this correct. So the answer is 5%. All right, so considerations with the neovagina. So there are benefits and risks to harvesting a segment of colon for neovagina. The benefits are that usually this provides a good length and width, and the bowel vagina is naturally lubricating and typically does not require routine dilation. But there are some risks to be aware of that can be managed. Some patients may complain of excessive mucus production, which can be treated with vaginal irrigations. We can see stenosis either at the anastomosis from the native vagina to the neovagina or at the introitus. Usually the stenosis at the introitus is very mild, and mild stenosis can be treated if the tissue is still very has good laxity. It may be treated with dilation, but if it's more significant stenosis, may need an introitoplasty. We can also see prolapse of the neovagina, and mild prolapse is usually treated with excision of excess tissue, but more severe prolapse or recurrence prolapse may require a suspension procedure or a fixation procedure. And then we can also see diversion colitis and inflammatory bowel disease of neovaginas, colonic neovaginas. So the colonic inflammation with diversion colitis is caused by a lack of luminal nutrients after the surgical diversion of the fecal stream. And so these patients can present with inflammation of the neovagina and discharge, pain, and bleeding. And so this can be treated with short chain fatty acid douches. And then some additional considerations. We've just recently done a literature review, and there are no cases of successful pregnancy in patients with a neovagina. So there is a case report of an ectopic pregnancy in a patient with a colonic neovagina, but no cases of successful pregnancy. And this is probably multifactorial and something that does need to be studied further. There are cases also of dysplasia and adenocarcinoma that are reported in the literature. And we presented a case here of a neovagina stricture that was complicated by high-grade dysplasia in a patient with a history of cloaca and then ulcerative colitis of her colonic neovagina. So any patients that present who have a neovagina that present with bleeding, pain, nodules, or stenosis should be evaluated with an exam, a vaginoscopy in the operating room to get a good evaluation of the graft, and then biopsy of any suspicious lesions. The most significant gynecologic concern that we see in infancy is the presence of hydrocopos. And with hydrocopos, there's no physical obstruction, so it's not entirely sure why this happens, but we do see distension of the vagina or vaginas with fluid, urine, and or mucus. And it's more common in patients with uterine duplication and a longer common channel. And this can also sometimes be identified antenatally on prenatal ultrasounds. So a poll for the group: what is the incidence of hydrocopos in patients with cloaca? All right, it looks like answers are kind of all over the place, but we see the correct answer is number 4, which is 30%. And then what are the indications to drain a hydrocopos? And here, the majority got this correct. Number 4, answers 1 and 2. So compression of the ureters and hydronephrosis, and then risk of infection. And then the last question about hydrocopos: what is the preferred method of draining hydrocopos? And again, the majority got this correct. Number 4, transabdominal catheter placement. All right. So the preferred method in the newborn period is a vaginostomy tube until definitive surgical repair is performed. So in this picture, you can see the transabdominal catheter here in the right lower quadrant. And it's important to know if there's a vaginal septum present. And if there is, the surgeon should create a window between both vaginas so that both can be drained appropriately. During infancy, it's also important to evaluate and identify the gynecologic anatomy. So we do this at the time of primary repair with an exam under anesthesia and vaginoscopy. So really, we're looking to see if there's no cervix, 1 cervix, or 2 cervixes. And this is typically, not always, but typically predictive of the upper reproductive structures, especially if you see 2, then you can be confident that there's 2 uterus or didelphys uterus. We also will evaluate the gynecologic anatomy with any abdominal surgery to use that opportunity to check the upper reproductive tract. So looking at the Müllerian structures, inspecting them, and then checking for patency as well. So patency of the Müllerian system can be confirmed by gently inserting a pediatric feeding tube through the distal aspect of the fallopian tube, and then instilling saline or dye to see if that goes through the fallopian tube uterus and then out the cervix into the vagina. And then you can see it at the perineum, the fluid. So determining the gynecologic anatomy can be challenging. There are plenty of cases or reports in the literature about patients where they thought Müllerian structures were atretic or not there, and then patients went on to have menstruation or obstruction. So definitely with any uncertainty, caution should be taken when considering removing uterine tissue, and we really should be only removing uterine tissue where we feel confident that there's potential risk for obstruction due to something structural like an absent cervix, so it's not a fully developed uterus. All right, so moving on to the period of puberty, patients with anal rectal malformations have normal ovaries, and so pubertal events occur as expected and will typically follow a very typical sequence. So girls start with breast budding around the age of 10, and then the landmark of puberty is menarche on average, although there's some variations, at about 12 and a half years old. And during puberty, really the focus is on menstruation. So we want to make sure that our girls who have an anal rectal malformation, that we follow them closely to menstruation and beyond. But we really want to make sure that if they're not menstruating, we know why, and making sure that the outflow for menstruation is patent. So we can see amenorrhea in about 20 to 30% of patients with anal rectal malformation. And this can be from hypoplastic or underdeveloped Müllerian structures, or structures that, or if these structures were removed during the initial reconstruction, or stenosis. So obstructed menstruation can be seen in up to 40%. And our goal is to always lower this and catch these obstructions earlier. And this can happen because of congenital and acquired causes. So we can see congenital causes from like septa or cervical agenesis, something that's blocking the menstruation. And then we can also see acquired causes, so stenosis that develops in the vagina. And obstruction of menstruation leads to retrograde flow of menstruation. So the blood will get trapped in either the upper vagina, uterus, fallopian tubes, and then go out the fallopian tubes and can result in an obstructive endometriosis picture. And this can be very painful for young women. So these are just some photos kind of what that obstructive endometriosis looks like. We can see that menstrual blood in the abdominal and pelvic cavities, kind of along the peritoneal surfaces, and then even here on the lower picture along the kind of scattered over the bowel. So obstructions can occur at different levels. This top picture on the left-hand side is menstrual obstruction occurring at the level of the cervix. And then in the bottom picture, you can see that this patient had a hemivagina or a Müllerian system that was missed and maybe not included in the initial repair. And then these are some MRIs of what menstrual obstruction will look like. So here you can see the uterus with this narrowing here, and then a bigger pouch at the bottom. This bigger pouch is the vagina, and then that narrowing is as the cervix. So here the obstruction is at the level of the vagina. And then another patient with a didelphys uterus where you can see menstrual obstruction throughout the uterus, and then even in the fallopian tubes, they're dilated fallopian tubes. So very, very, very important that we assess reproductive structures again during puberty, early in puberty, and throughout puberty, especially if that initial reconstruction involved the vagina. So how do we do this? We use imaging techniques with ultrasound and MRI, vaginoscopy, certainly if the patient is undergoing any surgical procedures, using that opportunity to look inside the vagina and see if you can identify cervixes. Saline perturbation of those fallopian tubes, again, if they're undergoing a surgery, and then examination of the introitus and perineal body. So when do we do that? At the initial repair, with any surgery, and then especially during puberty. And I typically recommend knowing that pubertal sequence with the breast budding starting first and period usually about 2 years after breast budding. I usually recommend starting that ultrasound surveillance or doing an exam under anesthesia 6 to 12 months after the start of breastfeeding, so that we could capture these, the patients at risk for obstruction before it occurs. And then certainly with any patients who have pelvic pain, low threshold to do an ultrasound, MRI, or exam under anesthesia. How do we treat menstrual obstruction? So there are preoperative strategies and then obviously definitive surgical management. With their preoperative strategies, you can use menstrual suppression, so hormones to kind of suppress further periods, ultrasound guided drainage, or a vaginostomy. And this is really the ultrasound guided drainage and the vaginostomy is to manage acute pain until definitive surgery is performed. And so for definitive surgical management, vaginoplasty if there is stenosis in the vagina. And then with the vaginoplasty, considering the age of the patient and if they're at risk for postoperative stenosis, either making sure that they can dilate or use a stent if they're at risk for that. If there's a septum that is causing the obstruction, then removing the septum. And then in rare cases where we've determined that maybe future fertility or pregnancy is really not an option for these patients or would be too high risk because of other medical conditions or surgical history, then in rare cases considering a hysterectomy. These are just some photos from an ultrasound guided drainage of a hematometria, so a menstrual obstruction with blood in the uterus. This is typically performed by our colleagues in interventional radiology, and we do recommend a percutaneous abdominal approach as opposed to like a vaginal approach. There's just higher risk of infection if the needle is placed through the vagina. So going through the abdominal wall into the uterus and then draining that obstructed blood from the uterus. And if the blood has been there a while, it can be very thick and clotted. And so we will also utilize medicine like TPA to kind of break up the clot and remove it from the uterus. So we use hormonal suppression of periods for obstructed menstruation, but then also any other GYN concerns that our patients with anorectal malformation may present with. So painful periods, heavy bleeding, or hygiene concerns if patients have other comorbidities where they're not ambulatory or using diapers, having a period on top of those issues can be challenging. And so you can consider hormones to suppress periods for that reason as well, just to help with any hygiene issues. So we use usually birth control to help suppress periods. And that can be given in the form of a pill, a patch, an injection. If a patient has a single uterus, a IUD is a great option to minimize menstrual bleeding as well. So moving on to sexual function, there are many, many factors that affect sexual function, and this is complex, especially in our patients with anorectal malformation. So certainly anatomy can affect sexual function. If a patient has stenosis, either at the introitus or in the vagina, that can play a role. Relationship status, medical comorbidities, so fecal or urinary incontinence. In fact, Dr. Wilcox had done a study and reported that patients with more urinary and fecal incontinence scored higher sexual anxiety. Spinal cord anomalies, adhesive disease that is causing pelvic pain. Certainly there are psychosocial factors and body image issues as well that can all affect sexual function. So patients that have introital or vaginal stenosis can be treated. So if it's mild, then vaginal dilation is an option. And then if the patient, if the tissue at the introitus is not, doesn't have good laxity, then considering an introitoplasty. And this is typically a minor outpatient procedure. And then in patients where there's scarring that is more significant, they may need a vaginoplasty or distal vaginal replacement. And unfortunately, the outcome data on sexual function is just very, very limited. We have a few studies. This study of 23 females with anorectal malformation ranging in age from 18 to 56 reported that 65% had had sexual intercourse, and 63% of those had reported painful intercourse. And then there was another study of 10 patients with vestibular perineal fistula that reported no difference in experience with intercourse, stable relationships, and orgasm, but did report that coital debut was delayed. So we have very little information right now, but the good news is that we have studies in progress. So we are looking at this here at Children's Hospital Colorado in our adult population, and we'll hopefully have some more data to share in the near future. And similarly, outcome data on fertility is very limited. So we know that spontaneous conception, we have these patients, we all know these patients, we know that spontaneous conception is possible, although our females with complex anorectal malformations appear to have a lower childbirth rate. And again, probably multifactorial. Mullerian anomalies are common, which can affect fertility. We can see iatrogenic damage, so scarring near and around the fallopian tubes from prior surgeries, endometriosis from obstruction, and then those psychosocial factors that can also affect sexual function. So what should we do to preserve or help with fertility? Evaluating the anatomy early and often should be a priority so that we can catch and prevent these cases of menstrual obstruction, because menstrual obstruction can significantly affect the fallopian tubes and then cause that endometriosis. And then work up for infertility and refer to a specialist early as well. And what we're starting to talk about here is, should we be considering fertility preservation in cases of complex anorectal malformation? So we know that the more complex anomalies are associated with lower fertility rates. So what should we be doing proactively to preserve fertility in these patients? These are just ongoing discussions and definitely more research that is needed in this area. And then moving on to pregnancy. So our patients with anorectal malformation absolutely need preconception counseling with a high-risk OB doctor before considering pregnancy. Because they have multiple comorbidities. They have cardiac issues, gastrointestinal, spinal, vertebral, renal anomalies, kidney disease, and all of that we can see worsening of certain diseases or medical conditions during pregnancy. So it's super important that they see a high-risk OB doctor. Also because Mullerian anomalies are complicated, and also because patients have a complicated surgical history. And we want to make sure that a plan is in place for delivery and emergent delivery by C-section if that is needed. So having the appropriate surgeons in place to help navigate this complicated surgical history in our patients that are going to deliver by C-section. I think this is the last poll for the presentation. This is a 32-year-old female with a history of erectovestibular fistula, pregnant at 35 weeks gestation, has good bowel control and an adequate perineal body. What mode of delivery would you recommend? Vaginal delivery, but avoiding any forceps or vacuum, vaginal delivery or forceps or vacuum, C-section, or I have no idea. All right. So I would say that this patient is probably okay for a vaginal delivery if she has an adequate perineal body, but I would want to avoid anything that is going to increase her risk of rectal injury. So avoiding an assisted delivery like forceps or a vacuum. So with mode of delivery, it really is dependent on the exam, the type of anorectal malformation, and the surgical history. So rectovestibular or rectoperineal fistula, it's probably okay for a vaginal birth. Again, if I had a patient who just didn't want to risk anything, then I think C-section can also be considered, but it's probably okay for a vaginal birth, but you want to evaluate the perineum, make sure that it's adequate, and then minimize the risk for sphincter injuries, especially in patients with good bowel control. So avoiding any forceps delivery or vacuum delivery, which increases that risk. Any patient with a cloaca or vaginal replacement should have a C-section. And then lastly, I just wanted to kind of highlight some consequences of unrepaired anorectal malformation in adulthood. We've seen a handful of these patients present to our center. A patient on the left was an adult female in her 20s who had chronic and severe constipation and painful intercourse and was found to have an unrepaired rectovestibular fistula. And then the patient on the right is a patient who presented to the emergency department with significant pain and bleeding after sexual activity and was found to have an injury into the rectum and an unrepaired rectovestibular fistula. So, important to recognize these and treat these to prevent these issues during adulthood. And that is the end of my presentation. I will stop sharing and take any questions.
Thank you so much, Dr. Alanis. You have so many questions. We're going to be busy for the next hour. Ask one live because I think it's very important. They ask, what do you do with a vaginal septum? How far do you go in the resection? And if you ever use a stapler?
So I've never used a stapler to remove vaginal septum. I just don't want to leave staples in the vagina. I think at the time of the initial repair, you go as far as you can, right? Sometimes you're limited by visualization, but if you can take down that septum during the initial reconstruction, certainly take it down as far as you can. And then, but if a patient presents during adolescence or adulthood with a longitudinal vaginal septum, then when they go to the OR, we take it down to the level of the cervixes.
Okay, I'm going to ask one more question live, and then I'll let you answer in the chat because we'll be here for 1 hour. How can you evaluate the function of a cervix if it's hypoplastic or abnormal appearing? And what are the indications for hysterectomy?
So I think certainly if you do saline perturbation of the fallopian tube and you see it come out of the cervix, then that is reassuring that the cervix is functional. I think it's hard to determine like if it's functional just by appearance. Typically the cervix has kind of like almost like a donut appearance, but we have seen cervixes where it looks a little bit more flush, but as long as there's an opening into that cervix, it should be functional. And then the second part of that question was
indications for hysterectomy. And there's a question, how do you pertubate the fallopian tubes, since we're in the same thing?
Yep. So pertubation of the fallopian tubes, a small feeding catheter through the distal end, being careful to, not manipulate the fallopian tube too much, but gently manipulating the fallopian tube, placing that feeding catheter through the distal end, and then instilling just a little bit of fluid to see if it goes through the fallopian tube, uterus, and out the cervix. And then indications for hysterectomy. This is, I think, should not be taken lightly because we don't want to take away these young girls' opportunity potentially for fertility. And so when we're considering hysterectomy here, at least here in the US, also there are laws in place that protect minors from sterilization procedures. Like it's against the law to do a sterilization procedure in a minor. So any patient that we're considering a hysterectomy on, we make sure that we get legal involved in and an ethics consult. And it really should be cases, at least in minors, cases where there is no option for future fertility and it's medically indicated. So somebody who has menstrual obstruction where the repair or the vaginoplasty is going to be very, very complicated, or they have underlying medical conditions where pregnancy is not really an option for them in the future. Those are cases that we might consider hysterectomy on, but very, very carefully selected cases with an ethics consult.
Thank you, Dr. Alanis. I will let you answer in the chat. As you can see, the questions keep coming, so you will be very busy in the next hour. We are very fortunate to have Dr. Alanis. She is an amazing surgeon and partner, and I think having a gynecologist meet our patients early in life and being able to be with them throughout life, being able to help them find a high-risk OBGYN, it's a privilege that we don't take it lightly. So thank you for being a great partner. So we're now going to switch gears and we're going to talk about bowel management for fecal incontinence. I just want everybody to keep in their minds that doing a good operation for these patients, it's not enough. If you made the perfect anus and the patient is fecally incontinent, your job is not well done because this patient will continue to suffer through life. So as much as we love to operate, we came to realize that the bowel management is probably one of the most important thing we can give to our patients. We really improve their quality of life by having proper bowel management. I don't know how many of you are familiar with this picture. It's truly one of my favorite one because it causes pain just by looking and knowing the history. So this was the first African-American girl that was allowed to enter what was an all-white school at that time. So there was a national exam and her mom decided to make her take the exam and she approved. And there were many protests of people that did not want to have children of different races in the same school. And as you can see, she's being walked by security and people are throwing tomatoes on her. And when I watch her interview now as an adult, she didn't realize at that time exactly what was happening, but we know what was happening was prejudice. And you may be wondering, why am I showing this in a bowel management lecture? And it's because patients that suffer from fecal incontinence, they suffer from severe prejudice, and we can help them. Bowel management is something that can be done everywhere, and it has a tremendously positive impact in our patients. So I hope you feel inspired to treat your patients, and we are here to help you because it truly makes a difference. So who are the patients that will need bowel management? Patients with anorectal malformation, patients with Hirschsprung, myelomeningocele, large sacrococcygeal teratoma, and traumas. So that question was in the chat before. So at what age do we recommend to start formal bowel management? At what age we want patients clean in the underwear for stool? 1 year, 2 years, 3 years, 4 years, or 5 years? Everybody can vote and we're gonna see the answers. Wow, all over the world. Well, it depends. It depends on at what age in your country other kids are out of diapers. So in the United States, it's starting between 3, but the deadline is 5. It's when the kids enter kindergarten. They should be out of diapers. So we want our patients to be out of diapers at the same age that other kids are out of diapers, either because they were able to toilet train because they have a good prognosis for bowel control, or because we're gonna keep them artificially clean in the underwear with enemas. So this talk has 2 parts. I am gonna talk about treatment of fecal incontinence, patients without bowel control. Then Dr. Dilator will talk about patients with constipation with bowel control. So we want you not to confuse that. So remember that fecal incontinence is normal at birth. We all wore diapers when we were babies. So our patients can be 100% fine with diapers until others are without diapers. So what are your recommendations until we start formal bowel management before 3 years of age? Give a suppository every night, give an enema every night, give a baby lax every night, avoid and treat constipation or constipating diet. Everybody can vote and let's see the answers. Avoid and treat constipation. That's correct. Patients with anorectal malformation, 75% of them will suffer from constipation, some of them with bowel control, others without, but our job is to treat constipation until the age of toilet training. So how do you decide if a patient with anorectal malformation needs laxatives or enemas? So first, you need to know what type of malformation does this patient have. The patient has normal sacrum, rectoperineal fistula, 100% chance of bowel control, vestibular fistula, 95%, bulbar fistula, 85%, imperforate anus without fistula, 80 to 90%, prostatic fistula, 65%, bladder neck fistula, 15%, cloaca with short common channel, less than 3 centimeters, 70%. That's for patients with normal sacrum. Patients that have a sacral ratio of 0.4 or less, those patients will be fecal incontinent, independent of the type of malformation. So the first job that you will have is to differentiate, does this patient suffer from pseudo incontinence, meaning that they are constipated and they have overflow incontinence, or they have true fecal incontinence, no bowel control. You're gonna determine the patients that have bowel control are malformations with good prognosis, normal sacrum, no tetrachord, they received a good repair. So those patients, they need constipation management, and that's what Dr. De La Torre will talk in the next talk. What I'm gonna talk are the patients that have true fecal incontinence, no bowel control. Those patients, they have a malformation with bad prognosis for bowel control, so rectal bladder neck, cloaca with a common channel more than 3 centimeters. They have a poor sacral ratio, less than 0.4, tetrachord, patients with myelomeningocele. Those patients have no bowel control. They will stay clean with a daily enema. So here's an example. This is a 30 years old male patient born and operated due to rectal bladder neck fistula. Remember the prognosis. He's complaining of fecal incontinence. Here is his sacrum. So remember how we are going to calculate the sacral ratio. So what does he suffer from? True fecal incontinence or fecal pseudo incontinence? Everybody can vote, and let's see the answer. 92% got it right. So rectal bladder neck fistula, only 15% of them will have bowel control, and those will be the ones with normal sacrum. If this patient has a poor sacral ratio, this patient has true fecal incontinence. Now look at this perineum. This was a patient that was operated not by you. So what treatment does this patient need? Laxatives or enemas? Everybody can vote, and let's see the answer. Enemas. Very good. So if we look here, you can see that the center of the sphincter is here. The surgeon placed the anus completely lateral. It's a patulous anus. The perineum is flat. This patient has no bowel control. Regardless, if you try to reoperate, this patient has no bowel control. This patient needs enemas. Very good. Now, what treatment does this patient need? Look at the perineum. Does this patient need laxatives or enemas? Everybody can vote, and let's see the answers. Half and half. Okay, so let's look carefully. Remember, you need good eyes when you're examining the patient. The center of the sphincter is here. So the surgeon placed the anus completely posterior to the center of the sphincter. This patient will not have bowel control. This was not a good operation. So this patient will need enemas. Now, what treatment does this patient need? Looking at the sacrum and assuming that the patient had a good operation. This is the preoperative image. Does this patient need laxatives or enemas? Everybody can vote, and let's see. Okay, we should not have gotten this one wrong. So this is a rectoperineal fistula. I told you this is a preoperative image. Assuming the patient had a good operation, this patient has 100% chance of bowel control. This patient should be treated with laxatives. I wonder if it's because you guys answered too fast before I said this was the preoperative picture. Now, what treatment does this patient need? Look at the perineum, look at the sacrum. Does this patient need laxatives or enemas? Everybody can vote, and let's see the answer. This patient needs enemas. So if we look at the perineum, we're seeing a flat bottom. If we calculate the sacral ratio, it will be 0. So this patient will not have bowel control. This patient needs enemas. So how do you decide if a patient, oops, I don't need this because let's do it. With Hirschsprung needs laxatives or enemas. I know this course is not about Hirschsprung. We have a full course of Hirschsprung, but since we're talking about bowel management, let's see. In patients with Hirschsprung, what are your options? Let's see the answers. Based on the amount and characteristics of the colon on the contrast enema, based on the integrity of the anal canal. So since only 2% of you got this answer right, I'm gonna say all of you that got it wrong needs to attend the Hirschsprung course. For Hirschsprung, patients are born with normal anal canal. So they are born continent. If the surgeon does the wrong operation, damages the anal canal, that's how these patients become incontinent. So I think we just realized everybody needs to take the course, Luis. So here's an example of a normal anal canal. And you can see this area here is the area that you're seeing smooth, is the area that allows you to feel the stool, the gas, the liquid, and decide if you want to hold it or not. Now, if you don't start the dissection at the right place, and Dr. De La Torre will teach you in the Hirschsprung course, then you end up with this, that there is no anal canal, and this patient has no bowel control. So once you determine if the patient needs, once you determine that we have a patient with fecal incontinence and the patient needs enemas, we're going to order a contrast enema, hydrosoluble material, and we are going to see if we are dealing with a patient with fecally incontinence and dilated colon, a colon that moves very slow, or fecally incontinence and non-dilated colon, a colon that has a tendency to move very fast. So here's an example of a dilated colon, and this patient will need a large volume concentrated enema to clean that colon. But once we clean that colon has a tendency to stay quiet. So this group is actually easier. And here's the concept of how we do the bowel management. We use a Foley catheter that we insert in the rectum, we inflate the balloon, and we pull back to act as a plug. Then we're gonna infuse the enema solution between 5 to 10 minutes. We ask the family, the patient, to hold the solution in between 5 and 10 minutes, and then they're gonna sit in the toilet, deflate the balloon for the remaining of the hour to empty the colon. And the goal after the enema is that we're gonna clean the rectum and the left colon, because it will take 24 hours for the stool in the right side to reach the rectum again, and it will be time to receive the enema. So the concept of the bowel management is very simple, but the beauty is that it works. And this is the second group, that it's the fecally incontinent with a non-dilated colon. That's a colon that it's constantly trying to move. This colon, we need a very small volume enema, usually normal saline only. Patients should get 3 meals per day, no snack, because every time we eat, we have a tendency to move our colon. And in many cases, we need to add medication, loperamide or Imodium, to slow down the colon in between enemas. So again, it's the same concept, but in this case, we will need the medication to slow down the colon between enemas. So we insert the Foley, we inflate the balloon, pull back to act as a tampon, and then we're gonna infuse the solution between 5 and 10 minutes. They're gonna hold the solution between 5 and 10 minutes, and they are gonna sit in the toilet between 40 and 45 minutes. The whole process should not take more than 1 hour. And then they are gonna clean that colon. But since this is a colon that tends to move very fast, we will need the medication to slow down this colon so the patient does not pass stool in between enemas. What is our recipe for the enema? First of all, there's no magic numbers. I'm gonna not tell you 20 mLs per kilo or based on the height or the weight. A general way to see is ask your radiologist to tell you how much it takes to fill the entire colon during the contrast enema. In our institution here, based on how much they use, I usually start the enema with 1/3 of that volume or less. Remember, you only want to clean the rectum and the left colon, so you need way less volume than what they use for the contrast enema. So the base of our enema is saline solution between 200 and 1,000 mLs. And the irritants that we're gonna use are glycerin, liquid glycerin. We use between 10 mLs to 40, but some cases we go up to 90 mLs. Castile soap, here they have packages, there are 9 mLs, but nowadays most people buy in bottles, so we can use 10 mLs, so between 10 and 50 mLs. And then we use the fleet as the last resource. It's very irritant, and that we can only use according to the age. Patients between 2 and 4 years of age, I only use half of a pediatric fleet, that's 33 mLs. Between 4 and 10 years of age, 1 pediatric fleet, that's 66 mLs. And if the patient is older than 10 years of age, you can use an adult fleet that it's 133 mLs. I don't go above in fleet. If you read the literature, there are reports of electrolyte imbalance and even death following fleet enema administration. So I use according to the age. And it's very important to understand this is a trial and error process. So for us, it takes us 1 week to find the perfect formula for each patient. And the only way to know if the enema has truly cleaned the colon is with an abdominal x-ray. The mom may say, oh, it was a fantastic bowel movement. I've never seen so much stool. But if the x-ray shows that there's still a lot of stool, that was not enough. We still have to make a more concentrated enema. So we modified the type of the enema based on the x-ray and the report from the patient. And one concept that it's important to understand is that we don't mix laxatives and enemas. Patients that have bowel control, they will receive laxatives, and Dr. Dilator will explain that. Patients that do not have bowel control, they need enemas. Why? If you ever have taken a laxative, you know that laxatives act at an unpredictable time, meaning you take the laxative, you don't know when you will feel the urge to have the bowel movement. The beauty of the enema is that you give the enema, the patient will have an immediate response. The patient will have a bowel movement at that time, at a predictable time. Now, if you give the enema, the patient has a predictable bowel movement, but then you give the laxative and the patient will have many unpredictable, involuntary accidents. So we don't want that. If the patient has no bowel control, the patient needs enemas. How do we give the enema? You saw it. We use a Foley catheter and we connect to a feeding bag. We use saline solution, but I think the nurses could type in the chat. If once the family starts doing the bowel management, we give them the recipe of how to make saline solution, but we emphasize that it's not like cooking. You cannot just throw as much salt as you want. You have to use the perfect measurement. So they make 1,000 mLs of saline solution, and then they will use whatever we recommend. We use lubricant. And if the child is small, they can be positioned in the mom's lap, or we can elevate the pelvis just to take advantage of gravity, or the child can position himself, herself. Doing it laying down on the side, it also works, but in some cases we need that gravity help. We use the balloon to act as a plug because it's important that all the solution goes inside. If we are leaking and the solution is getting out, obviously it is not cleaning the colon. So how do we troubleshoot, or how do we modify our recipe? For example, I'm going to say our most common recipe is 400 ml of saline and 20 ml of glycerin. Let's suppose I prescribe this for the patient. The next day, the mom reports that the patient passed stool. We call accidents when we see stool in the underwear. And when we look at the x-ray shows that there is a lot of stool. That means that my enema did not clean that colon. And we ask the x-ray to be done immediately after they are done sitting in the toilet. So they do the enema at home, sit in the toilet for 45 minutes, then drive to the hospital and get an x-ray, because then we'll see if our enema cleaned or not the colon. So in that case, I'll tell the mom, okay, tonight you're gonna do 400 of saline and 30 of glycerin, increasing the glycerin amount. Other option, the parent report that it took more than 1 hour after receiving the enema to have a bowel movement. Remember, we want the entire process to be 1 hour. So if it took more than 1 hour, that means that my recipe is not irritating that colon enough. I have to increase the concentration of the enema. So you're gonna increase the glycerin. Other option, the patient reported pain, nausea, or vomiting during the enema administration. The most common scenario is that parents let the solution go very fast, and then they had a vasovagal reflex. So what you can do is just slow down the administration. If the x-ray is clean, you can also decrease a little bit the concentration. If the x-ray is not clean, all you're going to do is decrease the velocity of the solution going in and warming the solution to body temperature. Usually those two maneuvers help. The other option is that the family said, child received the enema, had a good output, then started playing and passed clear liquid accident immediately after they started playing. So two options. Most likely the patient had residual fluid inside the colon. So we can try to decrease the volume of the solution, or we can just tell the family, once he or she is done emptying in the toilet, you can get the Foley catheter and just pass in the rectum without inflating the balloon and take it out to get any residual fluid that may have been trapped in the colon. And sometimes we look at the contrast enema, we look at the child, and we decided, let's say I say 300 of saline and 15 ml of glycerin. The next day, the mom says, you know what? When I reached 200, she could not tolerate anymore. So that means we will have to decrease the volume and the concentration for a volume that the child can tolerate. So I could say, let's try 190 of saline and 10 ml of glycerin, so that we are within that 200 that the child could tolerate. And the other option is you had the patient do the enema, the x-ray looks pristine clean, but the mom reports that the child is having true accidents, passing stool in the underwear throughout the day. That means we're dealing with a colon that moves fast, and sometimes the image may trick us. So in that case, if you have a clean x-ray, you know that your enema is cleaning, it's time to start the medication, the loperamide and constipating diet with 3 meals per day. So following those principles, we have an overall 95% success rate. So we're very proud of bowel management. It's a teamwork, and I cannot thank enough our ABPs and our nursing team because we could not do without them. So for patients with the dilated colon, we have 97% success. And with the non-dilated colon, we have about 81% success. And when I mention I have to thank the nursing team, I also have to thank the administrating team because scheduling those patients, it's a lot of work. So thank you all. Now, we have patients that come to us and they have received a stoma for life. For example, a patient with cloacal exstrophy is very common, or as Dr. Pena mentioned yesterday, a patient with trisomy 21 Down syndrome that they thought that the patient would not have bowel control. So one way to test and to show the family the effort in the event that they want to close this colostomy is to do bowel management through the stoma. So the way we do it is very similar. They are going to inject the enema through the colon. They will have a massive bowel movement. And our goal is that they will have an empty bag for 24 hours. If that happens, then they are candidate for a stoma pull-through in case of cloacal exstrophy. And the family and the patient will know the effort that they will have to do every day in order to stay clean in the underwear. And the other bowel management that we do, and it's not to have a patient completely clean, but you know that sometimes in patients with anorectal malformation, when we close the colostomy, they go through a period of diarrhea and severe diaper rash. So the abdominal x-ray always help in those scenarios. Most of the cases, they suffer from constipation and diaper rash. If that's the case, we can offer doing, in the United States, we have this PDLX, that it's a 4 ml glycerin suppository, that they can do it twice a day. That will provoke a better bowel movement and longer intervals without stooling. Usually that's enough to take care and improve the diaper rash. Now, if the patient is having too much diarrhea, then that's when constipating diet will help and sometimes starting Imodium. But you really need the x-ray to determine what is your patient suffering from. And remember, before 3 years of age, we are not concerned about keeping them clean, but we want to manage the diaper rash. Diaper rash can be extremely painful. If you have seen a child with severe diaper rash, open sore, it is the child is miserable. So we really need to treat the diaper rash. So how we do it? It's a 1 week period here in Colorado. We do the contrast enema, usually on Thursday. And then on Friday, parents receive a general information session about how the week is going to go. And in this information session, one of the doctors talk. Then we have one of the nurses explaining the technique of the enema. Then we have our psychologist and social worker giving them tips on how to talk to the child and to other family members. So the next day after this information session, they meet with one of the surgeons and we're gonna get an x-ray and determine what the treatment will be. So for example, this is the patient coming to see us on the first day, and you can see there's still contrast material from the day before. So that means this is a colon that moves very slow. So I decided to start the patient on 500 ml of normal saline and 10 ml of glycerin. The next day, you can see that there's no more contrast, but there's still significant amount of stool. And just to look at the x-ray, when you see this just black, it's gas. But when you see all this granulation here, this is all stool. So here there is stool, here there is stool. So the rectum and the left column are definitely not clean. And the parents reported that the patient passed stool in between enemas. So that means my enema did not clean that colon. So I'm going to tell tonight, we're going to increase to 500 of saline and 20 of glycerin. So now we are seeing that there is improvement. less accidents, but still a little bit of stool. So I'm going to increase a little bit more to 30 mLs of glycerin. And then I have a clean colon on the x-ray and a clean child. So I found the enema that works for that child. So this is another example, a 10 years old female with fecal incontinence. So what enema would you like to start her on? And I don't have a poll, but anything you start with, you will be right, provided you follow the patient and the x-ray. So let's say I decided to start in my most common one, 400 mLs of saline and 20 of glycerin. And what you're gonna do is compare the x-ray. So in this x-ray, you can see there is stool here. This is just gas. And then you see a lot of stool here. This is just gas. And then you see more stool here. Remembering, with the enema, you want to clean the rectum and the left colon. So I want this portion to be clean in the next x-ray. So let's suppose we did 420. Here's the x-ray, and you can see we cleaned the entire thing. This is a perfectly clean x-ray. And you can see it's the same patient because if you're a good observer, you saw that whoever closed this colostomy closed with staples, and the staples are here and the staples are here. So it's the same patient. So whatever you did good. This x-ray is perfect. If the patient is clean, continue the same. Now, this is an 11 years old patient with anorectal malformation. So look at the contrast enema. I think I have a question. Let me see. Oops, no, I don't. But looking at this contrast enema, what you're seeing is that this is a non-dilated left colon. So here's the abdominal x-ray on the next day. So you can see that you have no residual contrast. So based on this contrast enema and the x-ray, do you think we're dealing with a hypermodal or a hypomodal colon? Everybody can vote and let's see the answer. You're dealing with a hyper, a colon that moves very fast. Very good. So what enema do you want to start him with? 300 mLs of saline only, 300 mLs of saline and 1 pediatric fleet, 1,000 mLs of tap water, 300 mLs of saline, 30 of glycerin, and 27 of soap. Everybody can vote and let's see the answers. And the majority voted for 300 mLs of saline only. So if you're suspecting that you're dealing with a hypermodal colon, you don't need much. You can certainly start with just saline, and the next day you will know if you did the right choice or not. So the next day, the patient reported 6 accidents, and you can see that the rectum is clean, maybe a little bit of stool here, but it's a relatively clean. What do you want to do? Increase the concentration to 330, decrease the volume, or add Imodium? And the majority said add Imodium. If you're suspecting you're dealing with a hypermodal and you have a clean x-ray, you're authorized to start Imodium. Very good. And then you have a clean patient. Now you can see that the rectum and the left colon are clean. And just a quick comment, when we say clean, what we see in the x-ray is hard stool. Liquid stool, we don't see well in the x-rays. Now, patient, let's suppose that you are on call and a mother calls you at 2 a.m. saying that she gave the enema in her daughter today and nothing came out. She's a little uncomfortable but stable. What do you recommend? Give another enema, keep the child seated in the toilet, give laxatives, pass a Foley catheter and get as much fluid out and x-ray tomorrow or come to the emergency room. Very good. First question you should ask is, why is someone giving an enema at 2 a.m., right? I don't know why I wrote this question. I'm sure it was a true scenario. So what happens? Sometimes this scenario will happen and you can tell the mother to pass the Foley, get as much fluid out as possible. and an x-ray tomorrow if the patient is stable. If there is any concern, take them to the emergency room and get electrolytes, because sometimes patient is dehydrated, absorbs some of that solution, things can happen. But if the child is stable, pass a Foley, get as much fluid out as possible, and x-ray tomorrow is a safe option. For the same girl, the x-ray was sent and it showed accumulation of stool. So what is your recommendation? She needs a Malone, she needs a colonic resection, she needs a more concentrated enema, she needs a less concentrated enema, she needs laxatives. Everybody can vote and let's see the answer. She needs a more concentrated enema. Bowel management is something dynamic. Some patients, they leave that week and they stay with the same solution forever. Others, from time to time, we have to adjust. So if a problem like that happens and the x-ray shows accumulation of stool, no question that this patient needs adjustments. So we will increase. Now, for patients that need loperamide, it's called Imodium, we use according to the age. So for kids between 2 and 5 years of age, 1 milligram 3 times a day. Kids between 6 and 8 years of age, 2 milligrams twice daily. Kids between 9 and 12 years of age, 2 milligrams 3 times a day. Children older than 12 years of age, they can use up to 16 milligrams a day. So again, we try not to go above this recommended dosage. And for children that needs constipating diet, it's important to understand what are the foods that are laxatives, what are the foods that are constipating. And the constipating diet is very strict, so they cannot have any of the items in the laxative food. But what we tell the family is that we're going to be very strict during this week, that we are trying to find a way to keep your child clean. Once we succeed, then you're going to ask your child, what is the food that you miss the most? And they are going to say French fries. So for the next 3 days, you can give French fries. And if the child does not have accidents, French fries becomes a food that the child can have whenever they want. Then you ask the next question, okay, what's the next thing you mix the most? And they're going to say chocolate. So you gave chocolate for 3 days, the child had accidents the 3 days. So that means that chocolate is an offender for that child. Does that mean the child will never, ever be able to have chocolate again? Of course not. It just means that the child should have chocolate in a day that they are at home, and you will be prepared for the accident to happen, because it will happen. So most of our patients end up being able to adapt to a diet that keep them clean, and they have even the foods that cause accidents, but they prepare for them. They are not going to have on a day of school. They are not going to have when they go to a party, because they know the accident will happen. And once we have determined that the child needs enema, and we found that we have a recipe that works and keep that child clean, then the next step is talking about independence. How can we make that child more independent? Some patients are able to continue doing rectal enemas, and they are able to do it independently. But for some patients, this is not possible, and they prefer to have an antegrade enema procedure. We do the Malone procedure. We use the appendix. We plicate the cecum around the appendix to avoid leakage of stool, and we connect the tip of the appendix to the belly button in an almost invisible way. So imagine that the circle is the belly button. We place 3 silk stitches forming this triangle, and this last stitch should be at the deepest point of the belly button. And then we're gonna make the incision and extend. I have to say, when patients are thin, we can make a very tiny incision. I'm very proud that I can make like a 2 centimeter incision and do a nice operation. And then we're gonna find the appendix, open the tip of the appendix, and then with this triangular, flap in the belly button, we are going to anastomose to this opening of the appendix. So once we identify the appendix, you can see we have the cecum, the iliovalve, the ileocecal valve is away. We are going to create windows in the mesoappendix. And that's because we want to preserve the blood supply throughout the plication. Then we're going to lay down the appendix towards the cecum, away from the ileocecal valve, and we're going to use 5/0 silk, and we get a bite in the cecum, a bite in the appendix, a bite in the cecum to plicate this appendix. Then I also tag the cecum to the abdominal wall to avoid tension at your anastomosis, and we're going to do the Y to V anastomosis. So here's the V, and we're going to connect it to the deepest portion of our incision in the appendix, and we're going to suture the walls to the wall of the appendix. So this wall will be sutured to this wall, and this wall will be sutured to this wall. And then we close the abdominal wall, and we're going to leave this catheter in place, as I spoke earlier this morning, for 1 month. But the patient can start using to give enemas immediately after the operation. So here's a patient that has a Malone procedure, and here you can see with the catheter. So having a Malone procedure, they can swim, they can have normal life, and depending on the shape of the umbilicus, we can make it very hidden. As you know, some people have very flat belly buttons. Those are the ones that are difficult to hide, but we do the best that we can to make it as hidden as possible. And when patients don't have an appendix, then we're going to make an appendix, and we do it by creating a colonic flap. So we select a piece where we can see good vessels, then we mark with our bovie, our flap, and we're going to open this flap. We're going to insert our 8 French feeding tube. We're going to suture the colon and suture the flap around this tube. And then we're going to lay down away from our sutures. You don't want to lay down suture in front of suture. So you're laying down away from your sutures to create this plication. And then you're going to anastomose the tip of this new appendix to the belly button. So here's a real case. We selected where our flap's going to be. You can see the good vessels here. Then we mark with the bovie where we want to cut. And it's important that in the area of the tinea, you make it a little wider, because the tinea is not elastic as the rest of the bowel. Then we're going to suture the colon and suture around our tube. Then we lay down away from our sutures, create the plication, and we're going to suture the tip of this neo appendix to the belly button. And I think that's what I had for bowel management, and I'll be happy to answer any questions. So let me look at the chat. What about short appendix? How do you make the judgment before committing yourself to a certain incision? So what I do, I always start with a small incision, and I always have room to extend if needed. We have seen lap Malone plication is not necessary. So 50%, this is a study that Dr. Pena did, and he did not publish, but he started testing the continence of all appendix. And he found that 50% of the appendix are naturally continent. So it is true, in 50% of the case, you will not have problem, but having stool leakage through the belly button is something that it's very hard on patients, and then they would need a reoperation for plication. So we prefer to plicate all of our cases, and we don't have stool leakage. Do you perform contrast enema on a clean or full colon? Very good question. When we do the contrast enema for bowel management, we don't do bowel prep on them. We want to see what's the real anatomy. If the patient is very constipated, the contrast enema actually helps them clean out. So we don't do bowel prep. We really want to do it the way it is. Can you discharge a patient on concentrated enemas? Parents are adding glycerin at home. I'm not sure I understand the question. We do the bowel management as an outpatient procedure, but we are the ones giving them the first recipe and seeing the x-ray and orienting the parents what is the next change. So usually they consult us before changing the enema. Some parents, they become so experienced that they know how to make small changes and they call us to notify if it's working or not. What about Peristeen? Very good. Peristeen is a machine that delivers, it's the same concept, but it delivers the solution through pumping, so through pressure. So they don't need the gravity to give the enema. It is great. Unfortunately, in the United States, not all insurance company approves Peristeen. And Peristeen is a single-use catheter. So every time you need a new catheter. So if the insurance company does not approve, it costs about $3,000 for a family and no one can afford. So if the insurance company approves, we use it, but we still use with our recipe. The problem is you have to fill the entire bag. So we usually have to multiply our recipe by 3 and use 1/3 of the solution. Age for doing the Malone. So what I try to emphasize is that the Malone is not the treatment for the fecal incontinence. The treatment for fecal incontinence is finding the right enema recipe. The Malone is just a different route for enema administration. It does not make the enemas better. It's the same, but it's easier for independence. So ideally, we want to do it when the child is interested in doing the enemas themselves, or if the patient is going to undergo urological reconstruction, if they're going to undergo bladder augmentation, Mitrofanov, we do all together under the same anesthesia. So we try to do, in those cases, around age 5. Let me see if there are any other questions. Is there any role of artificial sphincter like gracilis sling? Unfortunately, not. The reason is the artificial sphincter is just dealing with the door. And for example, a patient that has fecal incontinence and poor motility, you open the door and nothing comes. So they will still need the enema to make the content come out. So for most patients, the artificial sphincter does not work. Do you adjust the recipe post-Malone? So the way we do it, once we do the balloon, we start with the same recipe as the rectal enema. Most patients, the same recipe work. Few patients we have to adjust. Should anyone try to stop management at any age? We will always be here to try to stop enemas and test if the patient has bowel control. That's something we always tell families. So even when the child has poor prognosis for bowel control, we will always give the child the benefit of the doubt to try to stop enemas and see if they have bowel control. If we can manage them with laxatives, we'll do that during a controlled week vacation. They are not on their school because we don't want accidents to happen. What is the end point of bowel management, if any? I'm not sure I understand the question. The end point is that I want a child completely clean in the underwear, being able to do any activity like any other patient that has bowel control. And if you watched the testimony of our first day yesterday, you saw JT doing his Malone flush at 16,000 elevation while climbing Kilimanjaro. So that's the end point, is quality of life. Can the Mitrofanov and Malone procedures be done in the same patient? Yes, we do all the time. So here I work with Dr. Duncan Wilcox, and he's very kind that he usually donates the appendix to me. and to Dr. Dilator, and he makes Monty Mitrofanov. So he uses a piece of small bowel to make the connection to the bladder. In my previous job in Cincinnati, we fought very hard physically for the appendix, just joking. But in that case, depending on what we decided, I would do a neo-malone and they would stay with the appendix sometimes, or I would stay with the appendix and they would have to do Monty Mitrofanov. Exceptionally, once in a lifetime, we find a 10 centimeters appendix that we are able to split and everybody's happy, but those are very rare. Do you do anything special for a malone in an obese patient? That's a very hard question. When patients have very thick abdominal walls, sometimes the appendix doesn't reach and the malone is not an option. So this is a very hard question. Sometimes we have even referred patients to bariatric surgery if they are extremely obese and wanting a malone. Any benefit on biofeedback therapy? We have never seen a patient that has true fecal incontinence, did biofeedback and became continent. So I love physiotherapists. I love to work with them. And I think there are certain indications, but specifically for fecal incontinence, I have never seen that happening. Do you involve the child in the decision of the malone? Of course, this is a decision that hopefully the child will be the one asking me for the malone. What about a button cecostomy? We prefer the malone because we don't have any foreign body. The button, you will always need to have something in there. And we, of course, receive all the ones that have problems. So the ones with granulation tissues, the ones that there's a lot of stool leakage. But I know some people do it and they like it. If it works, that's fine. That's not our preferred option. What about the microbiota in enema patients? Wow, that's a very good question. We were supposed to be studying that. We have the impression that we are changing the microbiota by doing enemas. So we would like to specifically study with fecal transplantation. But the problem in the patients that suddenly start having problems with enemas. But unfortunately with COVID, our study was completely shut down. So, and now there will be an oral capsule coming. So we have to wait for that until we start clinical trials. Did you do rectal biopsy to do, I don't know what HSD means, but patients with anorectal malformation, the chance of them having Hirschsprung is close to 0. Now, patients with anorectal malformation, the chance of them being constipated is close to 100%. So I would say operate on the patient, treat the constipation. Most likely this is not Hirschsprung. We only have 4 documented cases of anorectal malformation and Hirschsprung. And when this happens, it's a very sad scenario because patients will be fecal incontinent. Do you put these patients on long-term antibiotics? No, we don't do, I don't know what was the questions, but we don't put. What's the best group to respond to bowel management? Anorectal malformation, teratoma, or Hirschsprung? They all respond well, so they are just different. If you receive a patient with a failed button cecostomy, will you still be happy to go for a malone? That depends. In many cases, when they do the cecostomy, they remove the appendix. So we need to know if the patient has an appendix. If the patient does not have an appendix, we will have to do a neo-malone. Yes, we can do it. We don't do it at the same site where the cecostomy was done. I would be happier if I operated the patient since the beginning. Okay. I think I answered most of the questions. Yes, I think I answered. Perfect. Well, I think we now have a 10 minutes break, and then we will proceed with Dr. De La Torre's lecture about bowel management for constipation. So we'll see you in 10 minutes. Thank you. Okay, and I hope everyone enjoyed their quick break, but we are back, and it's now my pleasure to announce my great partner, Dr. Luis de la Torre, who will be talking about the second portion of what bowel management is, that is the treatment of constipation. So welcome, Dr. de la Torre. Okay, I'm afraid Dr. de la Torre is not listening. Yes.
Can you hear me?
Yes, we can.
Good morning, good afternoon, good night, everyone. Again, thank you for staying with us in this amazing workshop about colorectal problems, just dedicated for patients with anorectal malformation. So this conference is just to explain what we do in patients for bowel management in patients that suffer constipation. Just patients with anorectal malformation. It's similar our bowel management in patients with idiopathic constipation and Hirschsprung, but I don't want to talk about this other condition because it's a little different. So this is going to be dedicated just for patients with constipation after the repair, after the posterior sagittal approach and the repair. The first thing that I want to stress and I want to remark is when you have a patient with anorectal malformation and the patient after the PSARF with colostomy, you close the colostomy and then the patient start to have constipation. If you don't know how to manage this patient, the parents, and you as a surgeon, we live with anxiety and desolation because you cannot find sometimes the proper bowel management or the explanation to the parents why the patient is suffering constipation. And constipation is a spectrum. We already said that we talk about a lot about a spectrum in this course because constipation could be mild, moderate, or severe. So it is very, very common to see patients with constipation, and the most dramatic situation is when the patient also have accidents. In other words, involuntary bowel movements. In other words, the patient with constipation at the age of 10 years is using diapers or pull-ups, and they are discriminated at the family because they smell poop. At school, they suffer bullying, and they have fecal control. So in general, we can say more than 50% of the patients will suffer constipation, and you must treat this constipation before the patient suffers these consequences. You need to remember this. Every time you do a pull-through, you every time do a PSARF in a patient with rectovestibular fistula, rectoperineal fistula that has a very good sacrum, the patient is going to have fecal control, but the motility, how the colon is going to move the stool is different, is very slow. So the bowel management is a trial and error. I want to say treatment. So we don't have magic formulas. Diet is another common question. What is the diet for a patient that is 9 years and he had a rectoperineal fistula. What is the best diet? We don't have diet for a patient with rectoperineal fistula and 9 years. We can say that some foods produce more constipation than others. So you need to avoid these foods as much as possible, is the rule. Another big problem is when the doctors, when the surgeon, when the parents live the most extremely anxiety and desolation, then they believe that the patient has Hirschsprung, and the Hirschsprung associated with anorectal malformation is very, very, very rare. So now we have patients that they had a pull-through after the PSAR because the constipation was so severe, and now they have a pull-through, Suave, Swenson, or Duhamel, because the patient had Hirschsprung. This is a very common error. So please don't do rectal biopsies in these patients. Avoid these complications, because once you do a pull-through in a patient with anorectal malformation, because you did the diagnosis of Hirschsprung, now the patient is not going to have constipation. You are going to cure the constipation. You are going to fix this problem. But now the patient is going to have fecal incontinence. So the first question for you is, what patient require bowel management for constipation? Anorectal malformation with good prognosis, idiopathic constipation, patient with enemas and want to try to stop enemas, cloacas with a 3 centimeters common challenge or a normal sacrum, patients with a rectoperineal fistula, 1, 4, and 5, or all of the above. And the answers were all of the above. Perfect. So it's the most common bowel management in the world, the constipation. So you need to be expert in constipation, and I will try to do the best to explain what you need to do in patients with constipation. So the most common patients with anorectal malformation that we see with constipation, already Andrea explained this, is perineal fistula, vestibular fistula, vulvar fistula, cloacas with common challenge, and normal sacrum. And some patients that are in the borderline with fecal control, and they are very good with bowel management with enemas, but they want to try laxatives. So it should be a patient with hypomotility, patient with tendency to constipation, on bowel management with enemas, and we can try to do treatment for constipation and test in some way the fecal control. So the question is when to use laxatives or when to use enemas in these patients. First, you need to have a contrast enema. We strongly recommend to do a contrast enema before you start any bowel management. So to do the contrast enema, please try to don't to use barium, try to use any other like isobutane, which is not barium, because barium is going to produce stones. And please do not prepare the colon. We are not looking for polyps or diverticulitis. No, we are looking for the real state of this colon. This is just one of our patients with the history of a rectal malformation, and now he came because he has soiling. The patient is having pseudo-fecal incontinence because he's taking Miralax, and the Miralax, imagine the Miralax is the white area, the white liquid. So the Miralax is going to be able to move out. It's going to have bowel movements of the liquid, the white liquid that you can see, but the black zones is the dark zones are the hard poop. So the patient is going to move the soft or the liquid poop, and it's going to be an involuntary bowel movement. So the patient is going to have accidents. So number one, the rule number one of the step number one, do not give laxatives in a patient with fecal impaction. Fecal impaction means that the patient have hard balls of stool that cannot move out. The patient cannot have a bowel movement, just liquid stool or soft stool. And you take an X-ray and the rectum is full of hard ball of stool. This is a fecal impaction. So the first step is to do a clean out. So you can do our protocol, you can create your own protocol. So I'm going to explain our protocol to do this impaction. Once the patient is clean, probably for some days, I want to say, you can start to use the laxatives. So the laxative amount that we use must be adapted for every patient. There is no dosage based on the age, the gender of the patient, or the type of the anorectal malformation. A common question is, how many milligrams of Senosize is enough for a patient that is 6 years and she was born with a rectal vestibular fistula? There is a very common question that we receive every day. We don't have the answer for that type of questions. If you need to understand that every patient needs a different amount of laxative. So to do the disimpaction, you can use your protocol. One protocol is this one. You can use 3 enemas a day, so every 8 hours for 3 days, so 9 enemas, 9 enemas. The first 3 is with normal saline and fluid. Obviously, you need to know that the patient has good kidney function. The second day, 3 enemas with normal saline and glycerin. And then the third day, 3 enemas with normal saline and castile soap. The second option is to place an NG tube and give any polyethylene glycol with electrolytes for 2 days. And the third one is the disimpaction, the manual fecal disimpaction under anesthesia. You can combine whatever of this. The most important is at the end of the disimpaction, when you say, okay, the colon is completely clean, you must have the evidence of the clean out with an abdominal X-ray. When we start to use laxative, we guesstimate. In Spanish, calculamos the amount of laxative. Usually we start on Fridays when we do the bowel management, but we could be any day of the week. And then we said, okay, this patient needs 3 tablets. If the patient has diarrhea, we decrease the amount. I'm going to show you later with a diagram how we determine the amount of laxative. So the step number 2, the patient now is clean, you have a perfect X-ray, no poop in the colon, and then you need to try the laxatives. So let's start. So look at this X-ray, please. Look this X-ray carefully, and you will see something in the belly, something in the abdomen. Question, do you start laxative in this patient with a history of rectoperineal fistula during the bowel management? Is a patient with constipation, yes or no? 9% of the population in this conference is sleeping. So probably it's very late in your countries. Okay, so the response is no. 91% are awake. Perfect. So it's the same patient, the same picture on the left side of the screen. Now is the same patient after the clean out. We want to start the laxative just when we have the X-ray on the right side, completely clean. It's the same patient. You can see here and stable here and here because the patient was submitted previously as an other operation. So this is the perfect X-ray that we want to see before we start a laxative trial. What is the best laxative? Well, we want to stimulate only the rectum and the sigmoid. We don't want to stimulate the small bowel. We want to produce only one bowel movement a day. We don't want to have 10 bowel movements. The time of the bowel movement is predictable. So you can say, okay, if I give the medication in the morning, then the patient is going to poop at 2 p.m. Then makes a complete clean out of the rectum. You don't want to have residual poop after a bowel movement. Then you don't want to produce pain in the patient. You don't want to produce colicky pain in the patient. We want to have the laxative that we can determine the amount of laxative based on the weight. If the patient is 20 kilos, he needs to take 20 tablets. If the patient is 10 kilos, then the patient needs to take 10 tablets. We want to guarantee no more fecal impaction, no more accumulation of stool. We don't want to do another clean out in these patients. These laxatives should be available in tablet, liquid, drops, should have a good taste and not side effects. This is the ideal laxative. The bad news is that does not exist in the world. So we have at least 4 types of laxatives: fiber, softeners, osmotic, and stimulant laxatives. We don't want to use the 3 on the left side. We want to stimulate the motility of the colon. We want to stimulate the motility of the large bowel, the sigmoid and the rectum. And we have at least 3 common stimulant laxatives: senosides, bisacodyl, and sodium picosulfate. The senosides are the best. Why? Because they only work on the colon. Bisacodyl and the sodium picosulfate also works and are going to irritate the smooth muscle on the small bowel. And you don't know if the colicky pain is because the patient is ready to have a bowel movement or because the pain is the patient is having contraction in the ileum or the jejunum. And the senosides only work in the colon because all the senosides are inactive. They become active when they reach the colon, and the microbiota change the chemical compounds of the senosides and becomes active. That's why we prefer this laxative. Again, guesstimate the dose once a day. Never give the laxative like antibiotics every 6 or every 8 hours. We want to produce only one bowel movement, so just once a day. How many at what time we need to do? We need to give the laxative. This is an example. We give 4 in a patient with rectoperineal fistula, has a big poop, the x-ray is clean, so he needs to continue with 4 squares. This patient has 5 years, rectoperineal fistula. Next patient, other patient with the same problem, 4 years, rectoperineal fistula. The other response to 4, we said, okay, let's do the same. So we give 4 squares. And guess what? He has many bowel movements. You can see here, taka, 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 and another 2, and then mucousy, he's clean. This is an excessive amount, even when it's the same problem. So this is an excessive amount. Another patient, now is a patient, again, with a rectoperineal fistula, 4 years, but it's another patient, and we give 4. And guess what? A very little amount of poop, very small bowel movement. We get an x-ray and the patient has significant residual stool in the x-ray. So this is an insufficient dose. Then we have the 4th scenario. You have another patient with rectoperineal fistula, 4 years, you give 4 squares of senosides, and in 24 hours, the patient does not have any bowel movement. So the patient is not responding to this amount of laxative. So keep in mind, you can take a shot on the screen of this slide because it's how to do this laxative trial. You give 4 and the patient has adequate or excessive or inadequate response. If it's excessive, obviously you need to go down and give 3. And then you need to evaluate the 3 possibilities. If the patient has a good bowel movement and the x-ray is clean, you need to continue with 4. If the patient has an inadequate or no response to 4, you need to increase. But the good news is the patient needs an enema. You need to do a clean out with an enema and then increase the amount of laxative. So you need to be patient for at least a week in order to find the amount of laxative. You don't want to find the amount of laxative just in one visit, just in one clinic. You need to be persistent with this patient for at least 7 days. When to give the laxative? Well, if you know that most of the laxatives start to work between 8 and 12 hours, if you give in the afternoon, the patient is going to poop at midnight. If the parents prefer to have a poop in the midnight, you can give in the afternoon. If you give the laxative at night, the patient most probably is going to have a bowel movement in the morning before the patient go to school or before the patient go to work. If you want that the patient have a bowel movement after school, at home, after work, you need to give in the morning, sometimes around 7 or 8. So 1 week. During 1 week, you need to follow this patient and you need to do daily abdominal x-rays. It's the only way to be sure that the patient does not have residual stool and the colon is clean. What are we looking for in the x-ray? We look for a clean colon, the left, sigmoid, and rectum. We don't care that there is poop on the right side of the colon. Always it's going to have poop on the right side of the colon. The ascending colon is always with poop, which is normal. In patients with constipation, we want to keep clean after a bowel movement, just the left colon, the sigmoid, and the rectum. This is the patient that came for first time, 7 years, male, with a history of a rectovulvar fistula, normal sacrum, but used diapers because the patient was taking Miralax, polyethylene glycol, Contumax, any kind of PEG. So the next step is, do you think this patient needs a fecal disimpaction or you can start with laxatives? What do you think? Perfect, 97% are awake, only 3% still sleeping in the bed. Very good, yes, obviously this patient needs fecal disimpaction. Question for you, after a successful disimpaction, how much laxative do you want to start on this patient? Remember, he's 7 years, he was born with a rectovulvar fistula and has a normal sacrum. So pay attention, he's a male, 7 years, constipation, good sacrum, he has fecal control, now he's clean. How many squares? 3, 4, 5, 6, or 7? Perfect, nobody has the answer. So the answer is trial and error. You can start with 3, you can start with 4, everybody responds to 4, because in the example I gave you, I just put 4 squares, but I could put 7 or just only 2 squares. So you can start with 3, which is a good amount, 45 milligrams, 60 milligrams is also a good amount, whatever you want. But remember, you need to follow the rules. If the patient has too much bowel movement, you need to go down. If the patient is not clean, you need to go up and do an enema. Now, this patient, you give 4 squares or 3 squares, whatever you decide at home. And he reports that he has 3 voluntary bowel movements, which is good. He pooped on the toilet. no accidents. But he complains that the bowel movement is liquid stool, okay? So one goal is done. He's having voluntary bowel movements, no accidents, but the poop is liquid. And this is the X-ray. What do you do now? Do you increase the laxative because there is a residual stool in the X-ray? Do you reduce the amount of laxative? If you give 4, now you give 3, and you are going to add fiber to make the stool with more consistency, or say, take the same amount of laxative and add fiber. Okay, I am not going to increase the laxative, because if you increase the laxative, he's going to have, instead of 3 bowel movements and liquid, he's going to have a mess, diarrhea. What you can do is add fiber and see if he can have more solid, more formed stool, and will be great. Or you can decrease the amount of laxative. Now the patient have 3 voluntary bowel movements with good consistency because you add some fiber. And this is the X-ray. Remember, the right side, it doesn't matter. We want to see the left colon and the rectosigmoid. When is indicated the combination of enemas and laxative in this patient that suffer constipation? When are you going to give enemas and laxatives at the same time? In all patients who suffer fecal incontinence, in the group of incontinence constipated patients, in cases of fecal incontinence due to spina bifida, in patients who suffer from fecal incontinence due to an operation for Hirschsprung, or none of the above. Excellent, none of the above. We never use laxatives and enemas at the same time. We never use. Thank you very much. Just want to say that constipation in patients with anorectal malformation is a treatable problem. You need to be patient, and please don't think in Hirschsprung in these patients. Thank you very much. I don't know if we have time to answer live questions.
Thank you, Dr. De La Torre. I think we have 3 minutes for questions. So let's see if we can pick up a good question here. And everybody can type in the chat if you have questions, and even after Dr. De La Torre is done with his talk, he can continue to answer. In the clinic where I'm currently working, abdominal radiograph is not performed because of radiation. Is there any evidence that proves that it does not represent a risk?
Yeah, this is a very common question also from the parents. Nowadays, we have digital X-rays. Just you need to know, if you have digital X-rays, if you are on the sun, like here in Colorado, 15 minutes, okay? 15 minutes under the sun, is the radiation that you receive is the same that you have a CT scan of all your body. It's the same radiation. One CT scan, the radiation of one CT scan is more or less than 200 X-rays. So we only need 7 X-rays, at least, usually less than 7. So I want to say it's less than 1 minute under the sun. So it's not a big problem.
Thank you very much, Dr. De La Torre. So I'll let you keep answering questions in the chat, because I'm sure there will be many more. And it's my
Thank you very much. Bye.
Thank you. It's my pleasure to now invite Dr. Laura Judd Glossy, who is the psychologist in our team, and Christina Matkins, who is the social worker in our team. Welcome.
Thank you, Dr. Bischoff. Thank you all for joining us today. We are excited and honored to be here with you. Today, we will be presenting on addressing the psychosocial needs of patients with colorectal conditions and their families. My name is Christina Matkins. I'm the social worker with the colorectal team, and as Dr. Bischoff said, my co-presenter will be Dr. Laura Judd-Glossi, our team psychologist. Our goals for today are to review psychosocial challenges associated with colorectal conditions, share recent research, and to discuss effective strategies, including unique developmental needs. Research tells us that the longer a patient has incontinence, the greater the chance of developing behavioral and emotional problems.
Several years ago, we conducted a survey of adults with anorectal malformations because we wanted to get more information about their psychosocial functioning. We were able to partner with a private support group, which included 200 adult patients. And from that group, we had 70 people respond to our survey. Of those 70 participants, they ranged in age from 18 to 75 years old. About 3/4 of them were female. The remaining group was male. And as you can see, about 90% of them were Caucasian. They represented 12 countries across the world, although most of them, 60%, were from the US. We will be using quotes from this survey throughout the presentation to highlight some of the experiences of our adult patients. In high school and in my 20s, I suffered from depression, anxiety, anger issues, shame, embarrassment, and planned my own suicide due to the shame and embarrassment of living with the condition. I felt I would never get married or have children, that no one would love me or find me attractive. I had many accidents over the years, which caused me great mental anguish. All right, so here's our first poll question. What percentage of patients in our study do you think had a mental health concern? 15%, 30%, 50%, or 75%? All right, so it looks like the most popular was 75%. So we found that over 50% of our patients in this study endorsed a history of a mental health concern. So many of you were on the right track, that it was certainly very common to have a mental health concern. The most common mental health diagnosis that was reported was depression, followed by anxiety and PTSD, post-traumatic stress disorder. About 2/3 of the adult patients reported they had participated in some type of psychotherapy, and 50% of them indicated that they had used a medication to address a mental health concern, most commonly an antidepressant. Here's our next quote. Work is stressful and my management team isn't helping me. I feel as if I have to walk on eggshells just to do anything and hide the fact that I have to use the restroom so much. My family tries to help me as much as they can. So as you can see with this quote, we also wanted to get information about the participants' experience in school and their workplace. Here's our next question. What percentage of patients or participants in our study do you think felt that their employment status was related to their medical condition? 10%, 33%, 50%, or 80%? All right, so it looks like Most of you think 50%. I'll get to the answer in just a minute. Before I do that, I did want to speak a little bit about the frequency of school and workplace accommodations. So when I mention accommodations, what I'm referring to is the idea of patients having supports within the school setting or workplace setting. So for example, access to the bathroom or things like that. So our study participants indicated 1/3 of them received some kind of accommodations within their school setting. And interestingly, nearly 50% of them reported that they were not aware they could receive school-based accommodations. Similarly, within the workplace, about 1/4 of them, so 24%, received some kind of accommodations, but more than 40% indicated that they were not aware that they could receive accommodations within their workplace. Back to our poll question, so 33%, so about 1/3 of them reported that they felt like their employment status, meaning whether they worked part-time or full-time, was related to their medical condition. So overall, these results indicate to us that there's a need for increased education and knowledge for patients about school and workplace accommodations. Some of the accommodations that we would recommend within school settings include certainly having an access to the bathroom whenever needed. Ideally, students would be able to use a private bathroom, so that way they're not having to use a bathroom that has multiple stalls that might be uncomfortable for them to have to use the bathroom in front of other people. We also would recommend that there's some clear communication between the patient, the family, and the school team or teacher, so that there's a clear plan if the patient needs to go to the bathroom or hasn't had an accident, how they're going to communicate that to the teachers. Similarly, within the workplace setting, we would recommend that they have access to the bathroom, whenever needed, and the potential to work from home if needed as well.
I honestly wish I didn't have this problem. It's embarrassing and hard to get close to people. One of the common challenges patients and families experience is the struggle to gain support. It's easy for patients and families to feel isolated and alone. For many reasons, it can be difficult to talk openly about a colorectal diagnosis or issues with incontinence. Patients or parents may feel embarrassed, ashamed, a sense of guilt. Parents may worry about how they or their children will be perceived, and parents are often trying to protect their child's privacy. So sometimes we see this delicate struggle between trying to maintain their privacy around a private medical issue while also trying to obtain the support that they or their children need. Additionally, colorectal conditions are often invisible conditions, meaning that you can't necessarily look at someone and see the physical or the emotional impact. So that can lead to well-meaning friends or family minimizing the significance of the medical condition, which can then further isolate the patient or their family. Given the challenges that often accompany colorectal conditions, both patients and parents often will experience high levels of emotional distress. And of course, relationships with family members, friends, within the school or work environment and larger community can be impacted. For example, because of issues with incontinence, sometimes we see patients or their families limiting or choosing to opt out of social interactions. Things like attending birthday parties, going to sleepovers, going on school field trips, even canceling family vacations out of fear that they will have an accident or parental worry about how their child will manage their condition if they're not there with them. I was smelly and didn't have many friends, just 2 friends in grade school. Made me a loner and independent, which I still am today. I still suffer with social anxiety.
As you heard about earlier, we have a bowel management program that's offered every month here, where patients come for either an enema or laxative trial. As part of bowel management, we decided we wanted to get some more information about the psychosocial functioning of our patients and parents when they participated. So over the last 2 years, we've been gathering information both about parental stress, as well as the patient's behavioral and emotional functioning based on either the child's self-report, if they were 11 or older, or the parent's report of the patient's symptom if they were 10 or under. So over these 2 years, we had about 200 patients participate in bowel management and complete our measures. On average, the participants were 9 years old. They were 61% male and 73% Caucasian. You can see here in the graphic the distribution of the different diagnoses. So for example, sorry, we're not quite ready for the poll. I'll close that. So for example, 50%, so half of our participants had an anorectal malformation, 22% had idiopathic constipation, 19% had a spinal condition like spina bifida, and then 9% had Hirschsprung's disease. All right, now we can go to our poll. So what colorectal diagnosis do you think had the highest rates of parental stress? First, anorectal malformation. Second, idiopathic constipation. Third, a spinal condition. Or fourth, Hirschsprung disease. All right, so we've got people kind of in different spots. Looks like anorectal malformation is what people think is the highest. So let's take a look. So we actually found overall, all of the groups had fairly high levels of parental stress, which again is not surprising, but it was actually the idiopathic constipation group that had the highest level of parental stress. And it actually was statistically significantly different from the anorectal malformation group. From a patient standpoint, patients' behavioral and emotional functioning was poorest. So the most difficulty also with that idiopathic constipation group. Interestingly, a good amount of our patients who have idiopathic constipation also have a developmental delay or autism. And there certainly is a connection between those conditions and behavioral and emotional difficulties. So in some ways, it was not surprising to us that this idiopathic constipation group represented the most difficulty from a behavioral and emotional standpoint. And certainly these results also speak to the need for all patients and families, but particularly those with idiopathic constipation, to receive psychosocial support during bowel management.
So what helps patients succeed? We know that positive self-esteem and resiliency often go hand in hand, and providers can play an important role in this by using a strengths-based perspective in patient care. So for example, acknowledging your patient's strengths and reinforcing what they can do versus what they cannot. This can also be used when talking about treatment options as well, focusing on the treatment that you can provide for the patient. It's helpful to partner with families in advance whenever possible to identify coping strategies for the patient that can be incorporated into the treatment plan to minimize their stress. This can be things like the use of soothing music or listening to a favorite song, holding their favorite stuffed animal, taking deep breaths, or the use of distraction by utilizing an iPad or some other form of electronics. It's also helpful to partner with families and patients to identify what motivates them as well. This can be, again, use of electronics, a reward chart, a reward system, or some other motivator. My parents gave me the love and support I needed as a child and made me feel normal. My surgeon tried to give me a normal, healthy life, and I am grateful for these things. So what helps caregivers succeed? We know that connection with others is essential in our ability to cope with challenging situations, including managing a chronic medical condition. And of course, support systems can take many forms. It can include family or friends, coworkers, neighbors, faith community, a therapist, and so much more. What technology, though, has done is it's really allowed caregivers and patients to really broaden their support system to include websites, social media support groups, and networks. I think we all know that self-care is really important for all of us to maintain our overall physical, emotional, and mental health. We know that one of the best ways that parents can take care of their children is to take care of themselves. But that can sometimes be a difficult task because oftentimes parents are focusing 100% on their children and putting all of their time and effort into their care or taking care of them themselves. We know, though, that children are very in tune to their parents. So if parents' stress and worry is not managed and addressed, it not only can impact the parent's health, it can also negatively impact the patient. And finally, caregiver collaboration. There are three main components to successful caregiver collaboration, and that is coordination, communication, and consistency across settings. So whether there is one caregiver or many, whether the patient resides in one home or splits their time between two homes, it's important that everybody caring for the patient understands their medical condition, is knowledgeable about it, knows their medications and treatment regimen, is communicating with one another consistently, and that they are consistent across settings in providing patient care. This can be challenging sometimes when there is high levels of parental conflict. So in these cases, sometimes parents will utilize a communication logbook that they can pass back and forth between them before and after visits with the child. Additionally, another option for parents is to download a communication app that they can utilize to communicate via their phone or computer. Finding other parents who have children with anal rectal malformations. Connect with others and help each other. Find other children with this condition and connect your child with them. Acknowledge openly that your child needed special accommodations. So question 4, how can providers support their patients' psychosocial functioning? Number 1, ask about their mental health. Number 2, consider their developmental level. Number 3, share psychosocial resources. Or number 4, all of the above. Well, if you would have answered 1, 2, or 3, you would have been correct. But yes, absolutely. Number 4, all of the above is the ideal. I wish that those working in the healthcare field had told me there were many others like me. I wish they would have directed me to any resources that were available. I wish they would have asked me about my mental health. So how can providers best support their patients and families? We know that knowledge is power. So honesty and transparency in your communication and care of the patients and families empowers them, and that helps them to better cope and manage their medical condition overall. However, there may be medical discussions that need to happen initially without the patient present. This can allow parents an opportunity to ask questions, process information, get clarification before explaining the information to their child or before they support their child while you explain the information to them. And of course, it's always important to take into consideration age and developmental level when communicating information. Naturally, what we will communicate to a 5-year-old will be very different than what we'll communicate to a 16-year-old. And of course, taking into consideration developmental levels, that will also help to guide your conversations. Be proactive. Know the psychosocial resources in your clinic, hospital, community, as well as the websites, social media support groups, and networks. I also recommend that if possible, putting those resources into a handout that you can have readily available to give to your patients and families when needed. And finally, make it routine to ask at every visit how your patient is doing mentally, emotionally, and physically. And if there are identified issues, connect them with the appropriate support and resources. I wish I had opened up to a doctor and or asked more questions about my condition when I was younger. I wish children had a say in the medical treatment they experienced.
We also wanted to review some strategies that would be helpful for children and adolescents as they're beginning a new medical care, for example, in starting perhaps an enema program. So first, in thinking about children, it's really important to talk with kids about what to expect. So that way they have a sense of the rationale or the why of why they're doing something. So even with our youngest patients who are perhaps toddlers, we can use some really simple language to help them understand what an enema might look like. So at times I may say something like, you're going to have some medicine that goes into your bottom to help you poop. So this is, again, a very kind of simple, age-appropriate way to explain this to a young child. It's also helpful to use age-appropriate language in other areas related to medical terms or things like that. So for example, a child may not know what an enema is, so the family may decide to call it wishy-washy time. We've even had a family call it poopy bye-bye. Again, anything that helps the child understand what's going on with their body. Similar, a child may not know what a catheter is, but they may understand the idea of a straw or a tube that delivers their medication. It's also helpful to think about ways to involve the patient. So for our youngest kids, a lot of times they like to help shake the bag that has the enema solution in it. That can be kind of a fun job for them, or helping get some other supplies. And then finally, as Christina mentioned, it's really helpful to use activities to help with distraction during the enema. We know for a lot of kids, an enema can be distressing or uncomfortable. So whenever we're able to pair something that they really enjoy with that less preferred activity, that can make the experience go better. So for example, if a child has a favorite iPad game or show that they like to watch, we often encourage families to allow the child to only use that game or activity during the enema time. So they start to connect that the enema, while it's maybe not something that they really like or prefer, but they get something they really like during that time, which can be helpful for cooperation. When we think about adolescents, so our teens, we want to think about ways to really help them with independence and self-advocacy. So first, it's really important to include them within decision-making. So this may look like the teen having the decision around what time of day they're going to do their flush. Do they want to get up early to do it before school? Do they want to do it after school? Again, giving them those opportunities for independence. Similarly, we want to empower them to take an active role in their medical care. So perhaps after a teen has gotten a Malone procedure, we would encourage the parent for the teen to be able to take more and more responsibility over doing their Malone flush kind of step by step over time. So perhaps by the time they're in middle adolescence, they're able to do most of the Malone flush by themselves. It's also really helpful for providers to give teens the opportunity to meet with them individually. Often teens have questions related to puberty or intimacy and dating that they may not feel comfortable bringing up in front of their parents, but it's really helpful to give them that opportunity to ask any kind of private questions that they have. We also want to help support our teens in making and maintaining social relationships. We know that it's incredibly helpful for teens to be able to connect with others who have similar medical conditions or medical cares, who truly understand what they're going through. Thankfully, there's many different support groups that are available either in person or online or through social media that can help foster these relationships. And then finally, we want our teens to be focusing and working on the goal of self-advocacy. So the idea is that teens would be able to be familiar with both their medical condition and treatment. So by the time they're getting close to adult care, they know they're familiar with their medications, they know how to make an appointment, and they can explain their medical condition to their providers. There are several different psychosocial supports that Christina and I provide to our patients and families. So during bowel management, we provide a psychosocial lecture to give parents and caregivers some strategies and ideas about how to help support their kids during bowel management. We also offer support groups, both for kids and teens, as well as for parents and caregivers, again, so that they can meet others who understand what they're going through. We also have opportunities for them to meet either individually with Christina or myself. Usually Christina is supporting parents, and I'm often meeting with patients individually to kind of support them or work on anxiety and distress, things like that. And then finally, we're really a source of support around providing resources related to local and national support and groups. Just to give you some examples of some of the different local, national, and international resources that are available. Social media has certainly provided an opportunity for patients and families to connect with one another. So through Facebook, you may be familiar with Dr. Pena and Bischoff's Facebook page, which has a lot of really interesting and informative information for patients and caregivers. The Colorectal Support Network is a group that was started by several of our parents of patients with anorectal malformation, and is a place for adult patients and parents to connect with one another. There's over 700 members at this point, so I would encourage you to pass along that information to your patients and families, no matter what country that you're coming from. And then there's also private groups for adult patients with colorectal conditions, so that way they can connect with other adults in a very private, secure setting. On YouTube, Dr. D has a channel where he's recorded many videos and has information there about colorectal conditions and treatments. There's also several summer camps that are available. Within the US, there's a program called Youth Rally, which is a camp for kids with a condition that affects their bowel or bladder that are between the ages of 11 and 17. Many of our patients have gone to this and have reported it's been a really incredible experience for them. There's also something called the Serious Fun Network, which is a series of camps all across the world for kids with different medical conditions. So it's not unique to colorectal conditions, but our patients certainly can benefit from going to those camps and connecting with other kids. And then finally, there's a number of other organizations, both at the national or international level. One is called the Pull-Through Network, which is a group for patients of all ages, as well as families who have a condition that affects their colorectal or urogenital system. And then the 1 in 5,000 Foundation is an international organization that was started by an adult patient.
A colorectal condition does not mean you can't have a wonderful life. Don't let it stop you from following your dreams. This is one of our favorite quotes from an adult patient of ours. Finally, if you have any questions, please feel free to put them in the chat.
And here's our contact information. We'd love to hear from you. Feel free to email us if you have any questions that come up, or if we can be helpful with anything else.
Thank you so much, Laura and Christina. It's a pleasure to have you in the team and to support our families and patients. I think there's one question, if you have examples of the communication logbook or apps that you have suggested. Yes, that's the question.
Yeah, I don't have them with me here, but I'm happy if you took a picture of our email. I am happy to send you what that would look like. And then some of the common, probably one of the most common apps our parents use that I hear a lot is called Talking Parents. And that's one of the apps that I'm familiar with here. And there are a couple others as well.
Yes, and I think if you can type your emails in the chat, that will be helpful, because people, sometimes they see it, but they didn't take a picture. So thank you so much. And now we're gonna invite Dr. Pena to talk about reoperations in anorectal malformation. In 1 second, because, oh, here you go. Something happened because we're not. Just 1 second, I'll be back because I cannot see the file here. So let me close this. Doesn't let me. That's the file. Okay, now I can see. Okay, do you have an image, Ray?
Yep, perfect.
Okay, wonderful, thank you.
No me veo.
You're there. Can you see Dr. Peña?
Yes, we can. And here. Yep,
Perfect,
everything's good.
okay, you're there.
Good afternoon, good night, good morning, for depending where you are in the world. It is my pleasure to be back to talk about reoperations in anorectal malformations. And reoperations are very satisfactory many times because we can improve the quality of life of many patients. But at the same time, sometimes it's sad because we take care of patients that in the past had the opportunity to be completely normal if they had been subjected to a correct surgical operation. Yet, because of a surgical mistake, they would suffer from sequela for life. So hopefully in the coming years, we could see less and less reoperations in anorectal malformations. When we see a patient that comes suffering from, there are two types of reoperation. That's is very important to make that difference. The number one is when the patients come because they were born with an anorectal malformation, they were operated, and they suffer from fecal incontinence. And the question for us is, can we improve that? Can we give them back bowel control? And the second reason why we reoperate on patients is because they were operated for an anorectal malformation and something went very bad, very wrong during that procedure. And the patient comes with damages of many pelvic structures and many complications. So in those patients, represent a spectrum. Sometimes it's a minor damage, sometimes it's a terrible problem that we face. So they're referring to the first group of patients that come suffering from fecal incontinence. When they come to us, we have to evaluate them. We subject them to a full evaluation that includes, of course, a history, physical examination, an X-ray film of the sacrum and spinal films, kidney ultrasound, contrast enema, MRI, and based on that evaluation of the patient, we classify them. Those patients that originally were born with poor prognosis malformation. So they come to us with the expectation that we could do something to give them bowel control. Actually, they were born with a bad prognosis malformation. So they are not, there's nothing that we can do for them because they have a poor sacrum, they have Catheter cord, sometimes they have anterior meningocele. In other words, they were born with a bad malformation, and those patients that we call not trainable here, we consider them for bowel management. In other words, we manage those patients with enemas, and our goal is to keep them completely clean in the underwear, not make them normal. Simply, we implement our program of bowel management, and by doing that, patients improves the quality of life very significantly because now will be accepted in this society, can go to school, can have a work because it's clean. So the another group of patients that we find as a consequence of this evaluation is patients that are actually candidates for a secondary pull-through. This group of patients have specific characteristics, and I will describe those. These are patients that underwent an operation, but the previous surgeon put the rectum in the wrong location, but fortunately did not damage the sphincter mechanism. And so those patients have a good sacrum and the rectum completely mislocated, completely out of place. This group of patients, candidates for secondary pull-through, we used to see many of those in the past. They came from all over the world, and we have many patients that have the rectum here and the sphincter here completely out of place. But the sphincter was preserved intact. That's the great thing. So if a patient comes with a good sacrum, no tested cord, and a completely mislocated rectum, I won't going to repeat, completely mislocated rectum, that patient is a candidate for a pull-through. And we put the rectum back into the center of the sphincter, and a significant portion of those cases regain bowel control. When I performed the first reoperations for this group of patients and I put the rectum in the right place, I thought that all of them would have bowel control and would be normal. Very soon I learned that only about 50% of them actually regain bowel control, even with a normal sacrum in a completely mislocated sacrum. As time went by, surgeons all over the world learned more and more about the management of anorectal malformations, learn more about the real anatomy of the sphincter mechanism. And then we see less and less specific cases with a completely mislocated rectum. But you wouldn't believe, in the past we saw cases with the rectum completely out of place. Nowadays, fortunately, we don't see those cases, and therefore we do less and less of these reoperations. Now what we are seeing are patients that have a minor mislocation of the rectum, a real tiny mislocation out of the sphincter, but still inside the sphincter and with a good sacrum and fecal incontinence, or with a poor sacrum, and we don't reoperate on them. But some surgeons, over-enthusiastic surgeons, more popes than the Pope, they reoperate on them because they believe that they can improve bowel control. And we can tell you, minor mislocations of the rectum, do not operate on them. That's our suggestion, because those patients don't improve. Patients with a complete mislocation, only 50% of them improve, provided they have a normal sacrum. And then the third group, very interesting group. Please pay attention to this particular group. These patients, we evaluate, we perform all these studies, and we find that actually the patients were born with a very good malformation. And actually the surgeon did a good operation. So they have normal sacrum, not tested cord, a good malformation. They're supposed to have bowel control, and yet they come 5, 6, 7, 10 years old complaining of fecal incontinence. And what we do what we find in the contrast enema is a huge megarectosigmoid. A huge megarectosigmoid in a school-age child means, number one, that the patient suffers from severe constipation. But number two, that constipation has not been treated well. So we cannot emphasize enough the importance of the management of constipation in patients with anorectal malformations. The majority of patients with anorectal malformations will suffer constipation. And we are morally obligated to take responsibility and take care of the constipation that those patients will have for life. Only those who lost part of the colon have no constipation. Now, the constipation should not be underestimated in terms of complexity of the treatment. The management of constipation is something that the surgeons don't like to do. Again, because that's something medical and surgeons like to operate. But if you want to operate, you must take responsibility for those patients with constipation, because pediatricians and gastroenterologists are not familiar with the severe constipation that these patients have. It is not the same, the normal child that goes to the pediatrician because suffers minor constipation, and the pediatrician takes care of that by giving a mild laxative or fiber or something like that. No, these patients have severe constipation, and each one has a different degree of constipation. And it is our obligation to determine the degree of constipation of each patient. So since every case has a different degree of constipation, every patient needs a different amount of laxatives. We don't treat constipation with enemas. We use enemas for fecal incontinence. We use laxatives for constipation. But it's not simple, and it takes time. And it takes us about 1 week to determine the amount of laxative that a specific child needs. We do that by taking X-ray films of the abdomen. That's where most doctors don't like to take the time to do that. But it takes us 1 week taking an X-ray every day to see the location of the stool. Our goal is to see a colon completely clean of stool, radiologically demonstrated. So we keep increasing the amount of laxative. We usually use Senna laxative, and we keep increasing until we get an X-ray film that shows a complete colon. And at that, you would be surprised. But the amount of laxative that some of these patients need are sometimes double, triple, 5 or 10 times more than what the regular child needs in terms of laxatives. So once we reach that amount, it will take that amount of laxative to empty the colon, and that's what the patient needs. We give that, and at that point, we will learn in the next couple of days if the patient has bowel control or not. If the patient turns out to have bowel control and no soiling, that means that the patient was actually suffering from pseudo incontinence secondary to constipation, and it's a great result. The parents cannot believe that actually the child has been suffering. They thought that it was suffering from incontinence, but actually the patient has been continent all his life, except that did not receive the right amount of laxatives. So this is very important to keep in mind. This concept of pseudo-incontinence consecutive to severe constipation and the management with laxative. In a few cases, the amount of laxative that the patients need is so large that the parents have certain reasonable reluctance to give that amount of laxative, but that's what the patient needs. And if he doesn't take that laxative, the patient will become impacted and will continue soiling, behaving like being incontinent when actually it's really continent. So in those cases, we explain to the parents that if they don't want to do that, an alternative would be to give an enema every day. But to an enema every day is, from my point of view, I would prefer my son to take laxative rather than an enema every day. And also we at that point discuss the possibility of an operation removing part of the dilated rectum in the colon. Dr. Dilator will discuss more about that procedure. And the purpose of that is to reduce the amount of laxative that the patient will need. And finally, there is a small group of patients that had an operation for anorectal malformation. They have good prognosis, good sacrum, no tethecord, and the operation was done correctly, except that the patient is already 3 years old and still not totally trained. But we watch the patient and we try to help the child. If the patient is a little constipated, we help him with a little laxative. If the patient has a tendency to diarrhea for some unknown reason, we take care of that diarrhea. And we suggest the parents to give 3 meals per day in order to condition the colon to empty at the same time. In other words, we try to help the parents to train the child because the child has good prognosis. So for those that have poor prognosis, as I said, we suggest them to go for bowel management with enemas. For those that have a rectum completely mislocated with a good sacrum, not tethecord, we offer the parents a reoperation but we adjust the expectation. We tell them only 50% of our patients improve. And for those who have a minor mislocation, we do not offer an operation. And then for those who have severe constipation and chronic fecal impaction, they have pseudo-incontinence, we treat them with laxatives and or sigmoid resection. And for those who were born with a good malformation, we help them to become toilet trained. Now, for those patients that need a reoperation for fecal incontinence, remember our patients that were born with a good defect, had a good sacrum. What's happening here? They're born with a good defect, good sacrum, good sphincter, and completely mislocated rectum. And these are diagrams that show the type of cases that we found. These type of cases, I emphasize, is something that we saw very often in the previous years. when the surgeons were operating these patients blind, without an electrical stimulator, and without the knowledge of the anatomy of the sphincters. So we found patients, the most common mislocation was a rectum located anterior to the center of the sphincter. On a few cases, had the rectum located posterior to the center of the sphincter. And in some cases, the rectum was located lateral to the sphincter because they were just pulling the rectum like that. Fortunately, as I said, these findings are very uncommon at present time. So the obvious treatment for those patients that have a rectum mislocated is to open posterior sagittal and put the rectum in the right position within the limits of the sphincter, and with about 50% chances of improvement. Here you see a patient that said this center is the sphincter right here, and the rectum is completely mislocated anteriorly. If the patient has normal sacrum, we offer an operation. Now, if the operation that the patient underwent in the past included the resection of the rectum, we don't offer a reoperation because those patients will not improve. I'm going to repeat that. When the surgeon, for some reason, removed the lowest part of the colon, the rectum, leave the patient with no rectum, when you do that, you are removing the natural reservoir of the patient. Without a reservoir, what we do in Hirschsprung disease is to remove the reservoir, the rectus sigmoid, in most of those patients. And the patients have bowel control, provided we preserve the anal canal and the sphincter and we don't damage those structures. But those patients, even under the best circumstances, sometimes have minor accidents and have problems controlling. But a patient with anorectal malformation without the rectum will never have bowel control. Very important. So in this particular case, we have to reoperate and put the rectum back into the center of the sphincter. Look at this. In this particular case, the center of the sphincter is here. For that, you have to educate your eyes to know where the sphincter is, or use an electrical stimulator, and the center is right here, and the rectum is completely mislocated in the back. And this is another case. Look at this. This is the center of the sphincter, and the rectum is completely mislocated. So by putting the rectum here, if the patient has good sacrum, not at the core, and the rectum has not been resected, 50% of them will improve bowel control. Look at this. This case, another one, the rectum, this is the center of the sphincter. You don't need an electrical stimulator to see where the sphincter is, and the rectum was completely mislocated. So, we open posterior sagittal, dissect the rectum, put multiple stitches in the anal verge to put traction. Whenever you want to dissect something like the rectum, traction is the preferred maneuver. When you apply traction to any structure, anatomical structure, you create a plane. So it helps you because you can identify the plane. If you don't have traction, then it's very difficult and you may injure the rectum. So by putting traction in the way you see here, you were able to identify the rectum and respect the rectum during the dissection. And then you dissect the rectum and put it in mark the limits of the sphincter and put the rectum in the right position. Like that. So, and that's it, the end of a reoperation. That's another case you see. We see many cases like that. Now, the other group of patients are the reoperations that we call for other reasons, multiple reasons. And those are performed in cases that unfortunately suffer from a catastrophic procedure in the past. When we read the operative report of the surgeon that of a patient that had a catastrophic operation, you read the operative report and reads like a perfect operation, like everything went well. But when you go there to see the patient, you find incredible things, all kind of catastrophic things. One reason for the reoperation is recto-urinary fistulas, and we classify them in persistent fistula. We call persistent fistula a patient that was born with a recto-urethral fistula, was operated, and the patient has back the same fistula. Recurrent fistula is a patient that the surgeon was born with a fistula, the surgeon operated on the patient, closed the fistula, and the patient had a recurrence of the fistula. In the group of persistent fistula are cases that were born with a recto-urethral bulbar fistula. The surgeon entered from below or posterior saxal, found the dilated rectum and pulled the dilated rectum, but did not see the fistula. So that's persistent. It's the same congenital fistula that is there untouched. Recurrent fistula means that the surgeon identified the fistula, closed the fistula. And the most common reason why the patients have recurrent fistula is because the surgeons sometimes damage the anterior rectal wall. They closed the urethral fistula, but they left a damaged anterior rectal wall in front of the sutures of the fistula. Or they have put sutures in the rectum in front of sutures of the urethra. Sutures in front of sutures is an invitation to formation of a fistula. Acquired fistula are those patients that were born with no fistula, but the surgeon had the privilege to create a fistula that the patient did not have. And then a rectal diverticulum, I will mention a little bit about that. Here you see in this side of the slide, the patient had a pull-through, but its stricture and had a recurrent fistula. So the surgeon tried to mobilize the rectum, didn't mobilize the rectum enough, devascularized the rectum, and left the sutures under tension in a devascularized rectum, and the consequences an acquired atresia and the persistent and the recurrence of the fistula. And of course, we have to reoperate, redo everything, and put the rectum in the right place. These reoperations for catastrophic cases are very satisfactory because our procedure really makes a big difference. And see, in this patient, I open posterior saxally. This is the rectum, and there is the fistula. So I see, in order to take care of this fistula, not only close the fistula, if you just close the fistula and leave the suture of the rectum in front of the suture of the urethra, the patient will have a recurrence. But we have to mobilize the rectum to be sure that we leave a normal rectal wall in front of the urethral suture. They see another case, another patient that has the fistula here. Again, don't just close the fistula and you think that even if you use 2 or 3 or 4 layers, the fistula will come back. You have to, in this particular case, we had to put many stitches here in the edge of the rectum and pull the rectum down until we leave a normal rectal wall in front of the sutures of the urethra. And there you see, I already mobilized the rectum in this case, and this is the urethral fistula. This is a patient that was born with an perineal fistula, was operated, and then the patient was passing stool through the penis and urine through the rectum. And when you try to pass a catheter, it comes out through the anus, which obviously demonstrates the fistula. In this particular case, I approach the patient posterior saxilla. This is the coccyx. Oh, this is the rectum. This is the rectal lumen. And the surgeon actually pulled the rectum and sutured to the skin here, into the skin here, but left this virgin fistula. This fistula is untouched. The surgeon simply did not see the fistula or ignored the fistula. And why the most common denominator to explain all these complications, catastrophic cases, are patients that were operated, the majority of them without a high pressure distal colostogram. In other words, the surgeon did not know what was he going to find. So he opened looking for something. That's an exploration. And we insist that operations for unrectal malformation should never be exploration, should be perfectly planned procedures with a perfect knowledge of the real anatomy of the patient. For that, you need a good anatomic diagnosis prior to the operation, endoscopy, high pressure distal colostogram, so you can know what are you going to find. In the distal colostogram, you see the location of the rectum as related with the coccyx, because remember, we are working from below, just below the coccyx. So with the distal colostogram, you will know exactly what are you going to find. We have seen cases in which the surgeon, without the distal colostogram open, and he pulled what he thought was the rectum, happened to be a megaureter. Megaureter, sometimes ectopic ureters, connect sometimes to the prostatic urethra. And the rectum actually was located higher. So he found a tubular structure and pulled that mega ureter, actually. We have cases in which the surgeon found something that pulled it down, turned out to be the bladder, what they pulled down. So all kind of unbelievable cases we have seen. And all of them because the surgeon did not have a good high pressure distal colostogram. So this is the virgin fistula never touched and the rectum pulled down. And we have to redo. In this particular case, you see, this is an acquired fistula. You can see the difference between this is a virgin untouched fistula and this is a fistula that was done by the surgeon because you see all the scar tissue there. We have to mobilize all the rectal wall to expose the urethra, close the fistula, and then pull the rectum down. Here you see a little baby, a newborn baby that was born with a perineal fistula. Do not underestimate minor malformations like a rectoperineal fistula. Rectoperineal fistula, I'm going to repeat something that I said yesterday, is an excellent malformation. The baby has the gold opportunity to become a normal citizen if he finds the right surgeon using the right technique with knowledge of the problem. The perineal fistula, you have to move the anus back and take care of the stricture, but you must keep in mind that the anterior rectal wall is intimately attached to the urethra. And if you are not careful, you injure the urethra. So this particular baby had an operation for a perineal fistula, and then they called the surgeon at night because the baby was not passing urine through the penis. Another thing, don't ever operate a baby with anorectal malformation without a Foley catheter in place. So the surgeon did not put a Foley catheter in this baby, pulls through the anus, the rectum, and actually what he was doing, he divided the urethra and he was not aware of that and pulled down. This is the bladder, and they pull down the urethra all the way down to the perineum together with the rectum. So we have to redo the entire thing and reconstruct the urethra. Fortunately, the baby had bowel control and urinary control because a professor of mine used to say, babies are tough. Sometimes we try to kill them and they survive. And here you see the same baby, we put contrast material to the urethra and it was divided right there. And then I see the anterior urethrogram. This is where they cut the urethra. And this part of the urethra was originally here. The surgeon divided here and pulled rectum and urethra down. This should never happen if you follow the important principle. We have seen many urethral injuries. You see, this is acquired urethral atresia with acquired rectal atresia that we have to reoperate, reconstruct the urethra. That's where we develop our experience in reconstruction of the posterior urethra and took care of sometimes tumors of the posterior urethra. And posterior urethral diverticulum is very important to mention. Says those are the cases in which the surgeon divided the rectum here and left a piece of rectum attached to the posterior urethra, did not deal with the real malformation. We used to see many of these cases in the time when surgeons operated these patients abdominoperineal. In the old times, they either perform a perineal anoplasty or enter through the abdomen for abdominoperineal. If the baby was born with a rectourethral fistula, particularly cases with vulvar fistula, when the surgeon entered from above, it was very difficult for them to reach this point. So at some point he got nervous and decided to cut here and put the rectum down. So, and these patients go home and they had apparently a successful operation, but when they grow up, every time they go to pee, they pass urine, the urine comes out, but part of the urine goes into the diverticulum that keeps growing. And then when he walks around playing, he keeps dribbling urine that comes from the diverticulum. And in one particular case, the patient came up with a adenocarcinoma at the junction of this piece of bowel with the urethra. So nowadays, we saw some cases in the old times of the abdominoperineal procedures. These cases are coming back as a consequence of the laparoscopically repaired rectourethral vulvar fistulas. laparoscopy came to stay, and we welcome laparoscopy for those cases that require the laparotomy. Rather than laparotomy, you do laparoscopy. That's perfectly right. For patients with rectourethral vulvar fistula, we consider contraindicated to do laparoscopy because of these cases that we are seeing, and also we have seen severe damage to the urethra, because even with laparoscopy, sometimes it's very difficult as a surgeon divide the common wall without injuring these two structures and suture the urethra here and put the rectum down. So now these posterior urethral diverticulums are returning and coming back as a consequence of over-enthusiastic laparoscopic surgeons. Here is a case, you see a patient that was 13 years old, was dribbling urine, and you see the MRI, and then you see the bladder here, in a little structure here, and we kept going with sections, the bladder here, and the diverticulum here, and the bladder here is a giant diverticulum. So, now patients with unrectal malformations have a single opportunity like most patients with congenital defects. Pediatric surgeons should be the most delicate, meticulous surgeons in the world because we are dealing with patients with a life expectancy of 70 or 80 years. And therefore, I invite you, all of you, to be as delicate as if you were operating on your own baby. Thank you very much for your attention.
Thank you very much, Dr. Peña. And in the interest of time, Dr. Peña will be answering questions in the chat. And in about 30 minutes, we'll be answering questions again live. And now it's my pleasure to invite Dr. Dan Wood, who is the urologist that works with us in transition of care, to give his presentation. Welcome, Dr. Wood.
Dr. Peña, Dr. Bischoff, thank you both very much for inviting me to be part of this wonderful meeting. I'm going to give a much broader perspective, thinking about what happens to a child when they grow up, become a teenager, and then an adult. Really thinking from, this is from a urological perspective because we have some data around that, but it applies to all children who have complex anomalies that either they're born with or that develop during childhood. So when I first came into the type of work that I do now, it was initially 3 phases of pediatric, adolescent urology, and then adult urology. And what we've done over the course of my career so far is really make that much more of a seamless pattern of care, so that if you're born with a condition that affects you as an infant, that you have lifelong care, and we need to be strategic about developing that lifelong care. And there are all sorts of reasons why, and really the basis of this talk is to try and establish the importance of that in some of the complex anomalies that I deal with. So as a principle, this is important, that, that we kind of set up working groups and networks that can help to support and achieve this. And this is some work that I did in Europe, across both the ESPU, so that's the European Society of Pediatric Urology, and the European Association of Urology in collaboration together. We formed a working group that allowed us really to have a conversation about the complexities around this. And there is similar work going along in the US, which I'm also part of. But the idea was that to recognize that this work needs to be multidisciplinary. Pediatric surgeons and pediatric urologists are very good at identifying these patients, caring for them, and indeed identifying the fact that they need to move on to have complex adult care beyond the pediatric care they've had. But the problem is that there aren't many adult practitioners that have taken up on that challenge. And so developing that is really important. And that's been part of what we've tried to do, is to establish interest in the adult sphere, creating a network of people around that to support that and be able to consult with about difficult problems, and then providing guidance ultimately is what we'd like to do with standards of care, potential guidelines, and then ultimately to educate other people in terms of the work that we do and that we like to do. So why is it important? Well, in urology, it's important to understand that if healthcare is not set up well for moving from pediatric to adult care, then actually patients will disappear. And there's data that support that in the cardiac fraternity. If you have a good transition clinic, then you can keep your loss to follow-up rate down to about 8%. If you don't have that, then it's anywhere up to 50%. We know that as teenagers develop, that they develop understandably different priorities. They start to think about relationships with their peers. They start to think about sex. And of course, there are many issues around which they like or want privacy so that they can have confidential conversations, both within healthcare and potentially without. Also, as part of that is teaching them how to manage who they have in a consultation with them. I think it's perfectly fair to have a parent in with you, whether you're 5, 15, 25, or 35, because sometimes you hear complex information and it's useful to have that person there. But there may be elements of the conversation that you don't necessarily want to share with your family or your patient or your parents. So transition is really what that's all about. And it's about preparing a young adult for their move and their independence in healthcare. And that's the broadest definition of transition. A lot of people confuse it with transfer. That's moving a patient from one healthcare environment or one healthcare provider to another. Transition is much more about preparing the young adult, and transfer is just part of that. So there are lots of different ways you can do it. You can have a pediatric urologist or surgeon that follows a patient right through in an integrated department. You can have a pediatric or urologist or surgeon that follows their patient into a separate adult department with admitting rights in that adult department. Our model, both here in Colorado and where I previously practiced in London, is to see a child as they become an adolescent, to work with our pediatric providers, our colleagues, and then to take on their care so that we can then provide ongoing care in the adolescent and adult environment. The most disorganized or chaotic model is just that a patient is disseminated from pediatric care and sees an adult practitioner when needed. And often this leads to less than optimal care and sometimes disaster. So this is the essence. It's really teaching a young adult how to survive and be independent in their own healthcare environment. In the UK, there are lots of guidance documents, and increasingly we're seeing guidance around transition across the world. And it's important to think about how you are going to deliver those elements of service if you're delivering care to children, or indeed if you become interested in taking on transition and thinking about looking after patients as they get older. There are many tools out there. Some are good, some are harder to use. This is just a useful summary. It's not by any means a benchmark about when you begin the conversations around preparing for transition and empowering a young adult to develop their own interest in healthcare. And it begins really by asking them to think a little bit about their diagnosis, to think about the kind of treatment that they've had, and to be able to give their own account of that. And then as they become older and they develop, then it'll be less about the parents asking questions and making decisions. It'll be more about the young adult themselves asking those questions and making decisions around their own healthcare. We know that if that's done well, that in other specialties, they've been able to demonstrate a definite improvement in healthcare outcomes. So specialties such as diabetes, rheumatology, respiratory care, and oncology have all shown that by delivering a good transition service, it keeps patients within the service, it keeps them in the care that they need, and they get better long-term healthcare outcomes too. So there's a lot that we've learned, both from what people have done in the past and about what we would like to do in the future. My senior colleague on the right-hand side of this slide, Christopher Woodhouse, was really my mentor. I've also been privileged to work with the middle gentleman, Philip Ransley, in developing some of these areas. And the great forefather of all of this is the gentleman on the left-hand side, D.I. Williams, who really, with these two other gentlemen, had the foresight to understand that these pediatric patients were growing up and were going to need ongoing care in the future. There was a survey done in Britain looking at the need for it. And you can see that at that time, this was a few years ago now, that only about 2/3 were referring patients on to adolescents. Around 20% were keeping care under themselves. Some were just sending them on to adult providers. And the difficulty with that is the examples that I've given you. So in diabetes, there's a diabetic specialist in pediatric care. There's a diabetic specialist in adult care. If you look at respiratory work, there's an asthma specialist in pediatric care. There's an asthma specialist in adult care. If we consider posterior urethral valves, cloacal anomalies, bladder exstrophy, there is no adult equivalent specialist. And so these conditions being referred into a general adult clinic often means that somebody that sees them may not have the expertise in understanding either the underlying condition or indeed the treatment that may have been delivered beforehand. And therefore it makes ongoing treatment decisions very difficult. There's some background reading now. So together with colleagues, we have published a European and an international consultation. My colleague Christopher Woodhouse wrote an excellent book about it. And myself and Hadley Wood in Cleveland also wrote a book to really give people some background. So why is it important? And I think it's important to ask that question. If we're saying that this is something that everybody should be delivering and doing, then it's important to ask why. So this is the stuff that comes through the door of my clinic. On a weekly basis, we see a range of pediatric diagnoses, some acquired diagnoses, so ketamine damage to the bladder is one of them, and sometimes we see malignant change in relation to either underlying conditions or some of the reconstructions that may have happened. And it's important that we're able to recognize and deal with all of these. So multidisciplinary care is phenomenally important. I could not do this work on my own. It's really important that we have specialist nurses working with us, that we work closely with colleagues in nephrology, in colorectal, in gynecology, in radiology, in nephrology, and so on. Because all of those elements of care become complex and sometimes more complex as patients get older. So recognizing that and being able to support that is phenomenally important. It's really important that we understand what happens to these kids as they grow up, because not unreasonably, parents who are born with a child that has a major congenital anomaly will automatically, instantly have questions that they want to know the answers to. What's going to happen to their child as they grow up? What kind of surgeries are they going to need? What's going to be the outcome for them? They have natural parental concerns. And so when a child is born with a major anomaly, part of our job as adolescents and adult carers is really to inform the pediatric community about what is going on, what's happening to these kids as they get older, so that we can inform this very conversation. We know that in some conditions that presentations have changed. This is an ultrasound of a kidney of a young Serbian boy that I met when I was working at Great Ormond Street. And you can see here that he has a very nasty renal abscess. And this is how posterior urethral valve boys used to present in sepsis that was often fatal. And we know that that's different now. We know that presentations have changed. We know that many of these kids are diagnosed in utero. Therefore, they can have imaging when they're born, proactive management and drainage of the bladder, sometimes in utero treatment. But what's disappointing in this particular condition is that even though there have been improvements of care, it's been very difficult to demonstrate any improvement in long-term outcomes, particularly in terms of renal failure. So these guys often need to remain under the care of a urologist, but that's important information for parents to know when their child is born, for the child to know as he grows into being an adolescent and an adult, and to understand the reasoning and the basis behind that care as they go forward. If we think about patients with neuropathic bladder and wonder what aspects are lifelong, well, here's a list. Some of the things that kids worry about as they grow up are different from the things that the concerns that they will have when they're going through childhood, and quite rightly so. So in an adolescent and an adult clinic, we need to take these conditions, understand them, and be able to develop the conversation that adapts to their adult needs as opposed to their pediatric needs. And then some of the data that I've spoken about becomes really important in informing those conversations. So if we think about children with a neuropathic bladder, then we know that they don't necessarily have quite the same executive function. So complex decision-making for them can be really challenging. And they may even confabulate. It may appear that they understand information when perhaps they're not processing it on the same level that we might expect of them or we might need of them in terms of making decisions. So being aware of that, being aware of the limitations of some patients and understanding how we can assist in managing that becomes important. We know that when we've done things to patients, there can be consequences to that. We know that some patients who've had reconstructions of their bladder will be at a slightly increased risk of malignancy. There'll be some patients who are at greater risk, those with extrophy, those who are smokers, and those who are immunosuppressed are at greater risk of malignancy, and those with a gastrocystoplasty are at greater risk of malignancy. So knowing that means that we can cater for that in terms of how we follow up patients going forward. We can also give good news stories. So this is a paper from a hospital in London, St. George's Hospital, where they looked at the long-term outcomes of their spina bifida patients. And we would not have expected to see this number of people with normal renal function. And in fact, almost none of them with severe renal failure. And in fact, in this series, there were none of the patients died from renal failure at all. And that comes down to early bladder management and aggressive management of that bladder. So we can see that by understanding the longer term outcomes, we can inform and support what happens in pediatric care. And that's phenomenally important for future generations. For those patients born with neural tube defects, we can proactively manage that with them as they become teenagers and adults, and they start to think about having a family of their own. We can advise them if they want to become pregnant, they can dramatically reduce their risk of having an affected child by taking high-dose folic acid. That's very important in terms of how we deal with their ongoing care. If we look at a more familiar condition to many pediatric surgeons, hypospadias, we've learned over time that in the long term, testosterone makes no difference at all in terms of penile size, length, or indeed outcomes of surgery. It's still a subject of debate, but this excellent paper by Rinya helps us in understanding that testosterone doesn't seem to make a difference in terms of the long-term outcomes. But what does make a difference is understanding and following up patients, because we learn from these data here that actually our rather optimistic views in terms of the long-term outcomes of hypospadias were perhaps a little too rosy, and that the complication rate is a little higher, and puberty becomes an enormously important factor in that. And that doesn't just apply to hypospadias, it can apply in all sorts of scenarios. So understanding what your data is in the long term becomes really important in terms of how you're going to advise a patient. These are some data looking at hypospadias outcomes, just a summary table put together by Piet Herbecker from Ghent in Belgium in preparation for our EAU consultation or European consultation. And you can see that the data here are rather surprising. When many people would have quoted an 85 or a 90% success rate, actually what we're seeing is a larger number of patients with some of the concerns that I've talked about already. If we look at an extrophy boy as he becomes an adult, and we look at the effect that that can have on the penis, then how we counsel patients about what they can expect becomes really important, and managing their expectations is important. This is the penis here that's very recessed. These are the penile corpora, and you can see that's going to be difficult for him in terms of his ongoing sexual function. We know that extrophy patients, extrophy boys, have a reduced corporal mass. These are data from an MRI study done by Silva et al. In Johns Hopkins many years ago now, but still important data in terms of how we manage those expectations. But we also know that by understanding the anatomy of extrophy, that there is no cross-corporal circulation, which there is in an unaffected penis, then we can go on to manage that, and we can undertake appropriate disassembly to reconstruct the penis and correct those anomalies. When it comes to female genital reconstruction, understanding the optimal approaches and the options available becomes really important. So we can use perineal skin to reconstruct vaginas. We can use an obstructed vagina to create a flap that allows us to create a vaginal conduit down to the perineum. We can use ileum that we reconfigure to create a vaginoplasty. And these are all nice techniques that work well. This is an adult patient that we operated on when I was working in London. You can see small bowel here, ileum with an anastomosis, a reconfigured component, a portion of ileum that's been brought down to the perineum to reconstruct a vagina for this patient. And then in the long term, that's the kind of appearance that we would expect. So if we're going to do all of this work and we're going to understand that there are going to be data and long-term follow-up consequences for these patients, then we need to start thinking about, as a generation of doctors now, how realistically we're going to measure outcomes in these patients. And this applies across the board. It applies in colorectal medicine, it applies in urology, it applies in gynecology and other specialties too. So we could just look at complications and problems. And these are some of the complications and problems that we see in urology patients who've had long-term reconstructions, massive bladder stones. This young gentleman was a farmer working on the east coast of England. And his prostatic stone, which is that one there, had actually eroded out onto his anterior abdominal wall. He was lucky because the most common scenario is that it erodes into his rectum, which is then a much more difficult problem to sort out. We see biochemical anomalies that we need to monitor for, and we need to counsel patients in terms of how they manage their bladder. In the center of the slide, you're looking at a pot of mucus in urine and teaching patients how to wash out, how to manage their bladder so that they try and minimize some of these risks is important. But it's one way that we can measure outcomes. If we think about extrophy, then there are three major components to that. There's a pelvic anomaly with the diastasis, so there's an orthopedic problem. There's the urinary problem in terms of the bladder. And then in adult life, there's the potential impact on sexual outcomes, on sexual function. So which of these is going to be more important to a patient? And it's important for us as we go forward now and we start to see more of these patients as they grow up and progress through their adult lives, that we start to think about ways of asking those questions. Those methods at the moment are imperfect, but they're something that I think as a generation of surgeons, it's important for us to consider and work on. We do know, we do know that in extrophy patients, if we look at the center of this slide here, that their appearance and their discussion with peers really worries them. So thinking about how we can manage that, support them, and teach them techniques in terms of how they can disclose their condition if they want to friends and partners, and how they can manage themselves in social settings such as school changing rooms or going to the gym and so on, becomes really important to these. So understanding that and helping them to do that is part of what we need to be thinking about. We know that in extrophy ladies and many other conditions too, that they want to go on and have a normal education, a normal relationship, normal families and so on. And so part of our job in London was very much involved in looking after these ladies as they became pregnant, managing them through their pregnancy, and then working with our obstetricians to ensure a safe delivery. And certainly in extrophy patients, we found that it was phenomenally important that we were present at the birth for a cesarean section. And in fact, what we would do is begin the cesarean section, expose the uterus, and then allow our colleagues to deliver the baby through the cesarean section of the uterus. What's also important on this slide is just that bottom line, that we know that these patients who've got bowel in their urinary tract are at greater risk of false positive pregnancy tests. And that's probably something in the mucus that interferes with the assay of a urinary pregnancy test. So if you have patients with bowel in their bladder, a cystoplasty, and they're testing themselves to be pregnant, then they need a serum pregnancy test to confirm, or an ultrasound to confirm pregnancy. Otherwise, the urine pregnancy test may be false positive. So in summary, there are just a few things to think about. I think that one of the things that we deal with is managing expectations, and it's really important with the data that I've showed you and wider data too, that we understand that that whatever surgery is done, we can't make normal. We can improve function and we can try to make patients' lives better by improving function, but we cannot make normal. We may be able to improve appearance, but we can't make a normal appearance and so on. We also know that primary surgery is easier than revision surgery, whatever age of a patient. So if there is a need to operate on somebody at an infant age, then that's perfect and that's fine. But there needs to be a clear need and a surgical imperative for that. Simply operating on somebody for reasons of appearance, when that may go on to affect subsequent function, is a really important consideration. And there are now a lot of discussions around consent for that type of surgery. I'm not here to tell you what the rights and wrongs are today, certainly. That's an entirely different discussion. But when you're undertaking an operation on a child, it's really important to understand exactly why you're doing it, to be precise about why you're doing it, and to think about what the long-term consequences might be. So I think it's important to understand that these conditions are lifelong. So the amazing treatment that these children get when they're tiny is phenomenally important to set them up for a fantastic adult life. But they are likely to need, with complex conditions, they're likely to need lifelong care. And that's really what the service I've been part of and am part of is about. Many of them have had major surgery in childhood. And for that reason, as they grow and change, that surgery needs to be monitored to make sure that the outcomes that were initially good remain so. It's very important. We're really just starting to understand the importance of long-term outcomes and how they might shift and change, for instance, with puberty or growth or age and so on. So following that data through and developing that is really part of what we're about trying to do. Much more work is needed to understand that in detail. And if we're going to do this work well, it's not about working individually, it's about working as part of a shared multidisciplinary team. That's essential for good care at any age, but it's also just as important about guiding these children through adolescence and transition. I'm very grateful for your time. I'm very grateful for the invitation. Thank you so much for listening.
Thank you very much, Dr. Wood. And if there are any questions, I know there are several for Dr. Peña that we will answer shortly, but if there is any question for Dr. Wood, please, this is the time. I think as pediatric surgeons, we all are, it's clear that we need better transition of care. And I think it's our responsibility to advocate that for our patients. So we are very fortunate to have Dr. Wood working with us. I don't see any specific questions for Dr. Wood, which is a miracle. I think he was very clear. So thank you very much. And if there are any questions, please type in the chat, because I know Dr. Wood can still wait a few minutes and answer them. I'm just gonna share my screen for two meetings that I know this audience may be interested. So one is the Pediatric Colorectal Club that will be happening this year in Jerusalem, June 26 and 28. The abstract submission deadline is coming. It's April 22nd. One of the biggest advantage of this meeting is very friendly. Everybody that is interested in colorectal and urogenital conditions attend. And the publication, if your manuscript is accepted for publication, in 1 month after the presentation, it is published at the Pediatric Surgery International Journal, which I don't know any other meeting that the publication is so fast. And the next meeting is the WOFAPS meeting. That's the World Organization of Federations of Associations of Pediatric Surgery, that will be happening in Czech Republic, October 12th and 15th. And we will be giving a colorectal pre-congress colorectal symposium. It's gonna be very different than this one because it's gonna be 100% case-based. We're gonna be discussing real cases throughout the day. And we will be with Dr. Shilpa Sharma and Dr. Julia Brisigelli with us. So now we're gonna start answering questions, and we took some notes, but if there are more questions, please type in the chat. So I'm gonna answer regarding, can a contrast study make the diagnosis of a perineal fistula or a normal anus? No, because in a perineal fistula, if you remember the diagram, just the most distal portion is anteriorly located to the center of the sphincter. So the contrast enema will not be able to make this diagnosis. The diagnosis is seeing a fistula anterior to the center of the sphincter. It's very important to know the caliber of it. Remember, a newborn to 4 months of age should accommodate a number 12 Hager without anesthesia. We want, if it's a true anus, you will have sphincters surrounding it completely and you will have dentate line. So if you're finding narrowing anterior to the center of the sphincter, that's the diagnosis of a perineal fistula. And now Dr. Peña will answer a few questions. There was a question is a colostomy needed before a reoperation for anorectal malformation?
The question of colostomy or no colostomy to perform pull-through procedures of different types always comes in every meeting. And the answer is depends on your specific circumstances, depends on the characteristic of the patient and your experience and the environment that surrounds you. The best way to guarantee that your patient will not have complications like adhesions and infection is opening a preoperative colostomy. In general, we don't do colostomy for reoperations, but we are very conservative and very strict in the bowel preparation and in the postoperative follow-up. When the patient needs a reoperation, first of all, we clean the colon. Sometimes it takes 24 hours, sometimes it takes 3 days to clean a colon until radiologically we are absolutely sure that it's completely clean, until we see water coming out through the rectum. We prepare the colon with Golightly through a nasogastric tube and running constantly until we see coming water through the rectum. And also enemas if the patient is impacted in addition to the Golightly. So then we perform the operation and we keep the patients with nothing by mouth for 1 entire week receiving parenteral nutrition. Many surgeons don't like that because we are now in the era in which surgeons are competing to try to discharge the patient earlier and earlier. Hospital administrators are very happy when we say early discharge of these patients 2 or 3 days. There are many things that we can do, but doesn't mean that we should do. So we want to sleep comfortable, and that's why we are very strict and very conservative. No colostomies, but we clean the colon perfectly well and we keep the patient with nothing by mouth for an entire week. And we are very happy with our results.
So there's a question to clarify your comment about, or your quote about caudal regression versus caudal aggression.
See, that's a joke. That's a little bit of sarcasm from my side. Caudal regression is a term that many doctors like to use, particularly those who are very much embryology oriented. And it's a term, caudal regression, that includes many malformations. And that's why I don't use the term caudal regression, because when you say a patient has caudal regression, I don't know exactly what you mean. Could be a very severe malformation or could be something mild. So it doesn't tell me anything. So those terms, I don't use that. And caudal aggression means that a child suffers from an aggression, from trauma done in the caudal part, the distal part, the lower part of the body. So it's just a joke. So please don't take me seriously. I laugh about that.
This question has showed up many times. I have answered, but I'll let Dr. Peña answer also. Association of anorectal malformation and Hirschsprung disease.
So sometimes, occasionally, the Hirschsprung disease is associated with anorectal malformation, but that association is extremely rare. I'm going to repeat. It is extremely rare. In the last 50 years of my practice, we documented 7 cases of that particular association. That association of Hirschsprung with anorectal malformation is a very bad association because the patients need a pull-through. And a pull-through patient with anorectal malformation means fecal incontinence for life. So we have documented 7 cases, but on the other hand, in the last 50 years, we received many, many cases of patients born with anorectal malformation, suffering from constipation, that came to us with the diagnosis of Hirschsprung disease. None of them had Hirschsprung disease. So we pediatric surgeons were educated during our training to suspect Hirschsprung disease in patients who suffer from constipation. But Hirschsprung disease is much more than constipation. Hirschsprung disease actually is the main problem is enterocolitis, and the manifestations are not only constipation. So my advice, stay away from that diagnosis as much as you can, and question the diagnosis when the patients come to you, because I repeat, it is extremely rare. And if you make a pull-through and it turns out that it was not Hirschsprung and an anorectal malformation based on a misdiagnosis, you make the patient fecally incontinent.
So there is a question about PSARP versus laparoscopy, when each is indicated.
Well, as I said in my presentation, laparoscopy came to stay. It's a great advance in surgery. We like it very much, but it came to replace, in the case of laparoscopy, is to replace laparotomy. Yes, those cases that need an abdominal operation benefit by doing that in a minimally invasive way. In anorectal malformations, the malformation, specific malformation called recto-bladder neck fistula, where the rectum opens in the bladder neck, that's the only group of patients that need a laparotomy to repair in male cases, male. So though in those particular group of patients, recto-bladder neck fistula laparoscopy is a perfect indication. In addition, keep in mind that in bladder neck fistula, the rectum opens into the bladder neck in a T fashion. So for the laparoscopists like to put a clip or to a quick closure or a tie in a fistula. So you can do that in recto-bladder neck fistula. You cannot do that in rectoprostatic fistula, recto-urethral vulvar fistula. So if you are an enthusiast about laparoscopy, you start doing bladder neck fistula, that's perfect. You avoid the laparotomy. And then some enthusiastic laparoscopists go into prostatic fistula, where if you are well trained and you follow your patients and you have no complication, that's okay. But then over-enthusiastic surgeons, laparoscopists go into recto-urethral vulvar fistula, and at that point, we definitely consider a contraindication. Laparoscopy is also called minimally invasive surgery. Well, when you do laparoscopy for recto-urethral vulvar fistula, you are doing a laparoscopic maximally invasive operation, because recto-urethral vulvar fistula or vestibular fistula, we can repair with a 2-hour operation with excellent results without opening the abdomen. When you go from above to the abdomen laparoscopically to dissect the rectum all the way down to the vulvar urethra, you are dissecting the entire rectum unnecessarily. When you operate posterior sagittal, you just mobilize the necessary part of the rectum and keep the rectum and the rectosigmoid attached to the natural suspension mechanisms in the pelvis. And that's why patients subjected to laparoscopy for recto-urethral fistulas, they suffer from a high incidence of prolapse that should not happen.
So there's a question that I'm going to ask Dr. Peña and Dr. Dilator. What is the indication for sigmoid resection in patients with anorectal malformation and in patients with idiopathic constipation?
Well, let me first say something, Dr. Dilator. Dr. Dilator, I will expect him to describe a technique that he is using to remove part of the rectosigmoid when it's dilated, and he will explain his results, and I think that's a great operation. But much before that, years before that, when we confronted patients that, as I said, that required an enormous amount of laxative, that sometimes the patients take such an enormous amount of laxative, they throw up and nothing happens. When that happens, we consider the possibility to remove the most dilated part of the rectosigmoid. And by doing that, we were able to reduce the amount of laxative. We did not cure constipation. We simply reduced the amount of laxative, and we explained that to the parents. Occasionally, we were not able to reduce the amount of laxative. Most of the times, we were able to reduce the amount of laxatives. And then from there, removing from the abdomen the most dilated part of the colon, leaving the rectum intact. Because not all the patients improve as much as we wanted, then we move into pull through like a Hirschsprung, remove the rectosigmoid like a Hirschsprung operation. And for that, you end up paying a price, which is some degree of fecal incontinence in some cases. And then Dr. Dilator came up with another idea that he will explain you.
Yeah, can you hear me? Okay, I hope, can you hear me?
Yes, we can.
Okay, so the resection of the sigmoid in a patient with anorectal malformation was already explained by Dr. Peña, but I want to add something very important. If the patient has a dilated rectosigmoid, has constipation, but the patient has other conditions that probably make difficult fecal control, like an hemisacrum or a small sacral ratio or sacral ratio less than, I want to say 6.5. To remove this segment, most probably the patient now is going to have hypermotility or tendency to diarrhea, and is not going to be able to have fecal control. So we had patients that they had a very big, super big sigmoid or real megasigmoid, and the surgeons removed the sigmoid, but the patient has no sacrum. This is wrong. This patient needs enemas instead of laxatives. In patients with idiopathic constipation, the patient was born normal, no Hirschsprung, no anorectal malformation, nothing. It's a patient just with idiopathic constipation. So we don't know why the patient has this constipation. Some patients develop this huge or gigantic rectosigmoid. One operation is to remove the sigmoid, and sometimes we add a malone to improve the quality of life of these patients. A new operation that we are doing is a transanal resection of the rectum and the sigmoid, and we have to leave at least 5 centimeters of the rectum. Why we do transanal this operation? Because if you want to do the proctosigmoidectomy through the abdomen, the rectum is gigantic. Is very difficult to do that through the abdomen, and the risk to damage the urinary tract, the vagina, is really, really high. When we do this operation through transanally, I don't want to say it's a very easy operation. It's very challenging. Dr. Bishop is usually always with me to help because these operations are very challenging. But if we are very familiar with to keep the plane of the dissection very close to the rectum. In this way, we try to avoid any damage, but it's not an easy operation. The results for us are very, very good. So we are very happy with this operation, but it's very challenging. Thank you, Alberto.
So there is one important question that I would like to answer. If you're operating on a rectovestibular fistula and you find a very dilated rectosigmoid, is it better to do tapering or resection? So this is very important. If you're operating posterior sagittally, you don't want to resect that distal portion because that's where continence rely for these patients. So no resection when you're doing the PSARP. You want to do tapering to keep that distal portion within the limits of the sphincter. So again, that's why we say when there is a combination of anorectal malformation and Hirschsprung disease, you will have to resect the fistula tract and the rectosigmoid. Those patients are incontinent. So patients with anorectal malformation, we have to preserve the rectum. So no resection, just tapering. Do you ever consider laparoscopic resection for idiopathic constipation? Dr. De La Torre?
What was the question?
Do you ever consider laparoscopic resection for idiopathic constipation?
Yeah, you can do the laparoscopic resection of the sigmoid. In idiopathic constipation, don't be confused. I'm talking just related in patient with idiopathic constipation. If you are doing the sigmoidectomy, you have good chances to be successful. But in patients with idiopathic constipation, the most distal part of the intestinal tract, which is the rectum, is huge, is gigantic. And we have found many histological changes that are irreversible. One of them is fibrosis. The muscle, instead to be nice and red with the trichromic stains, the pathologist found disruption of these fibers and fibrosis in between. So in other words, instead to have muscles, the patients have fibrosis. That's why this patient, I suspect, they don't have good response to laxatives.
There's another question for Dr. Peña. If you have a newborn with a rectal bladder neck fistula, can you operate on laparoscopically without colostomy?
Yes, you can. There are many things that you can do, but doesn't mean that you must do or that we should do. So it's up to you. But first of all, the problem with the primary put-throughs in newborn babies is that the surgeons don't have the precise diagnosis. In other words, in a newborn baby, you don't have a distal colostogram. To do a distal colostogram, you need a colostomy by definition. So in that case that you mentioned, you are approaching a patient assuming that the patient has a bladder neck, may or may not have. Now, everybody, as I said, there is a competition between surgeons to discharge the patient very early and to operate the babies very early, and to compete as to who is more brave to do new things. And yes, that's welcome. Young surgeons should try new things, but be very careful, because when you are in doubt about colostomy or a primary put-through, think about your own baby. Assume that is your own baby. What would you do? That's the main question.
Dr. De La Torre, in your technique of resecting the hugely dilated rectal sigmoid transanally, isn't there a risk of overstretching the sphincter?
Yes, there's a risk.
There is a risk if you use like levers or huge instrumentation. We try to keep the dissection of the sigmoid externally. Once we have the plane of the dissection very clear, we try to keep the dissection out of the patient, not inside the patient. One of the common errors is try to do the dissection inside the anus, in the pelvis. The idea is to do the dissection outside of the pelvis, so you can cut the mesenteric vessels outside the anus. Yes, but of course, if you use devices or instruments that you want to stretch the anus, yes, you can damage the sphincters.
There's a very good question that I will ask Dr. Peña to answer. I see that you all do procedures for vestibular fistula in prone position. When do you do the anterior sagittal anorectoplasty?
Well, let me see. You can do these operations in any position you want. You can put it face down, you can put it face up, you can put it lateral, you can put it wherever you want, provided you separate the rectum from the vagina without injuring the vagina and the rectum. And provided you have a good exposure and determine the limits of the sphincter, and provided you put the rectum within the limits of the sphincter. Now, the term anterior side anorectoplasty. I don't like that term because means anterior side means that rather than making an opening posterior to the genitalia, you are making an opening anterior. So, and nobody does an anterior incision. So actually that term is incorrect, and the correct term is posterior side anorectoplasty in lithotomy position or in anterior or in supine position. That's the correct term of that operation. And yes, you can do it. As I said, you can do whatever comes easy for you. What is important is to keep in mind the goal. Your goal is to separate the rectum from the vagina without injuring the vagina. If you can do that with the baby supine, or do it whatever you want. That's it. But I don't think that's correct to say anterior side cell. It's posterior side cell in supine position.
Well, I think we answered all the questions. Well, there is one more. Can we use PSARP approach for treating rectosigmoid Hirschsprung disease? So can you use PSARP for a primary Hirschsprung? That's a good question.
Yes. Again, yes, you can, but we should not. Okay, I become very enthusiastic many years ago, and I started doing this posterior side approach for the treatment of Hirschsprung disease. And it was actually, I enjoyed that operation, but the problem is that a significant number of my patients developed a fistula, and they started passing stool through the posterior side incision.
Because you have to preserve the anus. So they end up with a T incision, the posterior sagittal incision, and a circular anastomosis. So that's why they developed the fistula.
So then I stopped doing that operations. In cases of reoperation for Hirschsprung, when there is a significant amount of fibrosis in the pelvis, the posterior approach is a one way to do it. It's a beautiful approach, but always with a protective colostomy. Because if you don't use a protective colostomy, the patient will keep trying to pass a stool through an area of a sphincter. In other words, your anastomosis is going to be proximal to the sphincter. It's like creating an obstruction distal to an anastomosis, and the patient will create a fistula. I hope I was clear.
So the question about, yes, let me just answer one question. The question about antibiotics during bowel prep. This data is from adult patients. We do not use antibiotics in our bowel prep, and we do not have postoperative infections. Dr. G, do you want to answer? You wanted to say something?
Yes. I don't want that everybody have the idea that we do many resections in patients with constipation, because in the chat there are many questions about it. So our bowel management in patients with constipation, idiopathic constipation, and constipation in patients with anorectal malformation is very successful. I think we can do probably around 10 cases every year. But remember that we receive the worst patients that have been treated previously for many years by the GI, another GI, pediatrician, nutritionist, psychologist, psychiatrist. They have many, many years with constipation. So we receive the worst cases. We don't receive very easy cases. That's why we came with the idea with a new operation, not because we want to do operation. Constipation should be a medical problem, not a surgical problem. So keep in mind that the resection that we are doing is in severe cases. Thank you.
So there is a question for Dr. Peña. Dr. Peña, have you seen complications when you do a PSARP without a colostomy, when you do it?
Yes, we don't have complications, and we believe that because we are very strict in our bowel preparation and very strict in keeping the baby and the patient with nothing by mouth for one entire week and parenteral nutrition. Now, having said that, we have seen many serious complications and patients that were approached for different reasons, Hirschsprung or anorectal malformation, major anorectal procedures without a colostomy. What you don't want to see a dehiscence and retraction, dehiscence and sepsis in a baby that you did a put through without a colostomy, because that's a terrible experience for the patient and for the surgeon. We had many of those cases that we had to reoperate and open a colostomy. So I could comment much more on that, but in our cases, we don't see that. We are very conservative. We move very carefully when try to optimize the management of patients.
So regarding the size of the posterior sagittal incision, it really does not matter. Do whatever size you need to have a right surgeon, a right surgery without complications. I always tell my trainees in the beginning, make sure you extend, because the plane is easier to find deeper in the rectum than close to the fistula. As you get more experience, you can try to limit your incision, but remember, this is an incision that will be in a spot that will rarely be seen. So don't be afraid to extend if needed for the benefit of the patient. Let me see what's the other question here. At what point in age does a pediatric surgeon transfer the management of some of these patients with complex malformation like cloaca malformation to other specialists like obstetrician and gynecologists? So our patients, they see the gynecologist since the newborn period, and the gynecologist, in our case, our gynecologist, Dr. Alanis, she stays with the patient throughout adulthood because she also sees patients at the university, and she's able to make the connection with the fertility group or the high-risk OB when this patients wants to start planning for their families.
Well, let me say, I'm retired. I retired a year ago, and I like to continue following my patients. So I advise my patients, and I will continue advising for life. When I said transfer, I don't give up my patients. Since I ask for help for gynecologists, for urologists, gastroenterologists, adult colorectal surgeons, but I like to feel, the patients like to feel my presence, even if it is virtual. But I'm curious. I want to know what happened to my patients.
Okay, I think, I'm not sure if Dr. Peña finished the reoperation lecture, and I don't think we had time to talk about rectal prolapse, but we will have the entire presentation available. It has the technique that we use. Sometimes we still use, and the new technique that Dr. De La Torre described, there is an article with beautiful images on how we repair too. Can avoiding cystogram help in seeing a fistula? Yes, but it can help miss a fistula too. We think that the best study is the distal colostogram, because you also need the information of how much bowel you have, how much distal bowel you have available for the pull-through. Well, I think we answered most of the questions. I don't think we will ever be able to answer all your questions. So I just would like to thank the Hendren Project, and especially Ray Evergan for his technical support. We could not do this course without him. And then I would like to thank all the members of our center. This is a teamwork, and we could not do our work without them. So we have our administrative team, that is Sue Danielson and Peggy Chavez. We have our nursing team, Annie, she's in the audience, and Maura that will be joining us. We have our medical assistant, Brianna Brown. We have our database analyst, Victor Rodriguez. We have our research manager, that it's Jill Katzer. We have our APPs, Julie Schletker and Hope Siemens. We have our fellow, Leah Weirley. So it's you saw today our social workers, Christina Matkins, and our psychologist, Dr. Laura Jude Glossy, our urologist, Dr. Duncan Wilcox, Dr. Kyle Rove, Dr. Dan Wood, our gynecologist, Dr. Veronica Alanis. It's really a teamwork, and I hope I didn't forget anyone. And I'll let Dr. Pena give the final words, and we hope that you all dedicate to treat those patients, because we truly need more and more people dedicated to this condition. So thank you for attending the course, and I'll let Dr. Pena give the final words.
So we are very happy. We are a little unhappy for the fact that we can not see you and touch you and make a toast together like we used to do in our in vivo courses. But as I said at the beginning of this course, the good side of this story, or the pandemic, or the virus, is the fact that now suddenly we had, how many?
Yesterday we had 2,200 people attending. I don't have the final numbers for today.
So this is unheard. This was a big surprise for us. That means that in the previous 60 or something courses that we ran all over the world, we had a limited audience, only those who could pay the trip and the fee for the course. Now, because of the pandemic, and because of this wonderful technology, now we can talk to people in the other side of the earth, and for no price. So we feel very happy. We never expected that 2,000 people will be watching. So we feel very happy about that, because fortunately we have been all over the world traveling in the past, and we know that not everybody has the privileges that we have in taking care of the technology that we enjoy in taking care of our patients. So please accept our admiration, and I'm talking on behalf of Dr. De La Torre and Dr. Andrea Bishop. Accept our admiration, all those surgeons who are trying to improve the quality of life of these patients, working under difficult circumstances, adversity, economical problems, material, technology, and they still are working very hard to improve our children. Our admiration and respect for all of you. And we want you to know that here in Denver, you have friends, and you can come to see in vivo all that what we are saying is really true, and we'll welcome you. Thank you very much.
Thank you. Dr. De La Torre, do you want to say a few words?
No, just say thank you, everyone, and see you in the HISPROM course.
Perfect. On Tuesday, we will have the nursing and the APP course. So if you enjoy the course, remember this is a teamwork. You need your nurses to learn too. So please ask them to join, and doctors are more than welcome to join too and learn from a different perspective. So thank you very much, and we hope to see you soon somewhere around the world.